I'm going to go ahead and sort of begin introducing the morning as people come in with their coffee, finish up getting their breakfast, and as we corral our third panelist for the morning. I just want to spend a few minutes, if I may. I'm Alan Weil, Editor-in-Chief of Health Affairs. We're really excited about today's event. I typically just launch into the event, but I do want to give a couple of minutes of background. This is I have a personal interest in how this topic plays out and want to share with you a little bit of the story of how this event came together. It's really a joint brainchild. I want to acknowledge Chip Kahn at the Federation of American Hospitals. He and I were talking. He and his team had a paper in Health Affairs a little while ago about sort of the complex dynamics of the pay-for-performance elements of Medicare for hospitals. And here we are in this world where all sorts of payers and purchasers are moving to wanting to pay for value. They are defining and measuring value each in their own way, and there's this overlay of programs, and we keep adding new ways of thinking about value and how to pay. And the question is there any coherence, and how do the various pieces fit together? And we had that conversation in the context of another development, which is that shortly after I began as editor-in-chief, almost 2 years ago, we had a thematic issue on big data. And those of you who are out in the field know that there's increasing use of predictive analytics and lots of other data mining techniques designed to personalize medicine and think about people's care and care pathways in a much more nuanced way. And yet our pay-for-performance measures are still quite rudimentary. I'm not saying they're unimportant, they certainly are. But things like readmissions, even healthcare hospital-acquired conditions are a narrow slice of what anyone would define as quality in healthcare. And so we just started talking about, given the progress we're making as a country, as a health system, in increasing the availability of data and using it in new ways and thinking about quality in different ways, isn't it likely that we will soon be thinking about paying for value in different ways? Don't we need to start laying the foundation for a different conversation that is not these broad metrics like readmissions, but are much more tailored to individual patients, their individual circumstances, and their individual preferences, which is another area where our sense of quality is evolving. And so what we put together is a half a day, to look at the current methods that we use to reward payment and value, and then to start a conversation about what the next generation of value-based payment might be, acknowledging that there are multiple goals here. There's rewarding good performance, there's encouraging better performance, there's transparency of performance, and all of those elements have to be present. We also struggled with the notion that there are hospital payment methods and there are physician payment methods, very much on in the news these days. There are also ACO and other integrated and bundles and lots of different ways you can slice and dice who is part of the value equation. But we decided that to not try to take on everything, although that's always tempting. We would focus on hospitals, we would focus on physicians, and use those sort of as the anchors because they are the most dynamic at the moment, and then try to bring it all together. So I just thought hopefully thought it worth sharing a few minutes of the genesis, so you have a sense of why we thought today was important and what we were hoping to accomplish. We were able, with Chip Kahn's leadership, not only to conceptualize the event, but to gain financial support for this event. I want to acknowledge the Federation, but also the American College of Surgeons, the Blue Cross Blue Shield Association, Johnson & Johnson, the American Medical Association, Booz Allen, and Premier, all of whom helped make today possible. And really, we couldn't do this without their support, and I'm very appreciative of it. I want to now turn to our panel, but I still see an empty chair, which is making me a little nervous. I can't conjure up people. We have lots of powers at Health Affairs, but that is not one of them. I think what we should do is acknowledge that since I missed an event not long ago for traffic, I know these things happen. Let's go ahead and begin the conversation, and we'll have a good one nonetheless. It's very difficult to shoehorn these complex topics into very short presentations, but we've asked in the name of having more of a dynamic session and conversation for our presenters to stick to 7 or 8 minutes, which can't do justice to any of these topics, but is hopefully a good place to start the conversation. So we're going to focus first on the hospital side of the equation and where we are and what some of the challenges are around paying for value in hospitals, where we already have existing programs, of course, in Medicare. We're going to hear from David Baker, Executive Vice President for Healthcare Quality Evaluation at the Joint Commission, which, of course, is outside Chicago. We're going to hear from John Perlin, President, Clinical Services and Chief Medical Officer of HCA, the nation's leading provider of healthcare services based in Nashville. And hopefully we'll be hearing from Cheryl Damberg, Rand Distinguished Chair in Healthcare Payment Policy and Professor at the Pardee Rand Graduate School. So let me turn it over to David.
Thanks very much. So at the Joint Commission, our mission is to improve quality and safety. So in the very brief time that I have to speak today, I'm going to focus on how we can modify value-based purchasing to drive improvement. So I'll talk about the hospital-acquired conditions, the readmission program, as well as value-based purchasing, and try and bring those together. So one of the first things that we need to do is shift away from hospital-acquired conditions and think about measures of all-cause harm. Currently, major causes of harm are not measured. So, for example, medication errors are one of the most common cause of very serious harms. Many of the measures that we have are invalid. The severity of the event is not considered. And at least in the hospital-acquired condition reduction program, it's only the lowest quartile that's penalized. So we need to develop valid measures of all-cause harm, and this is not an easy task, obviously. I think it's important to have all-cause harm because right now people think about reducing central line infections or these different pieces. And what we need to do is to get hospitals to say, how can we be a safe hospital? And to get that focus, we need measures of all-cause harm for those hospitals. And I think doing this would really incentivize a culture of safety across the hospital. We need to incorporate weights for harm severity. Obviously, a catheter-acquired urinary tract infection is not the same as wrong side surgery or wrong patient surgery or accidentally nicking the spleen and having to take out the spleen. So we need to focus on harms because this is what's most important for patients. And we need to think about how we can increase the penalties and set up a program that really is going to incentivize improvement across the entire spectrum so that each patient matters. Every patient will move you up the scale. Second, there's a lot of talk now about simplification. How do we bring all of these different programs together in this morass? And one of the things that I think we are at the point or near the point is it's time to retire the readmission reduction program and focus on admissions. If you look at the data on this over the last 7 years, 30-day readmission rates have declined from 21.5% to 17.8%. From 2007 to 2015, and almost all of this took place between 2010 and 2012. There's been virtually no decline over the next 3 years after that. In other words, the juice has been squeezed. Now, the latest studies suggest that a small proportion of readmissions are preventable, depending upon which study you look at, somewhere between 10 and 25%. So flip that around, and between 75 and 90% of admissions are not preventable. So much of the remaining differences between hospitals are spurious and do not reflect true differences in quality. So we need to incentivize preventing all admissions, and this obviously is one of the goals for the alternative payment models and the bundles. I'm a primary care physician. I could have a patient admitted 5 times per year and not get any penalty for readmissions, but yet many of those admissions, those initial admissions, were preventable with really high-quality care. The next thing is we need to get back to using measures for improvement. Process measures led to unprecedented improvements in quality between 2002 and 2015, and I'll show you some data on that on the next slide. In fact, this was so successful that many of these measures were retired because they were topped out, because most hospitals in the country were between 95 and 100% on these measures. So this is a little bit of a complicated slide, so I'll take you through this. First, if you focus on the blue line and the right axis, you can see the number of measures that were in national accountability programs. So if you look in 2002, there were about 6 or 7 measures, and then gradually over time that increased, and then this gigantic jump up to a maximum of 49 measures. The red line shows the percent of hospitals that had greater than 95% performance on a composite of all those measures. In other words, this shows the proportion of hospitals that were really high performing. And at the start, you can see only about 15% of hospitals, 10% of hospitals fell into that category. But then what you see is this steady increase in the number of high-performing hospitals, including during this time. If you look here, the measures are skyrocketing, but the rate of high-performing hospitals is continuing to go up. So hospitals had the quality improvement infrastructure in place that they were able to accommodate these new measures and continue to improve quality. So can we reproduce this quality escalator? So introduce national goals and measures, facilitate and reward improvement. This is something that the hospital associations have talked about, Joint Commission has talked about this, CMS is interested in this. How do we reproduce this tremendous success story that we had during the last decade? So the idea is you introduce these measures, you rapidly try and improve to a very high level, and then when those measures are topped out, you can shift them to maintenance. Our belief at the Joint Commission is these shouldn't really be retired. They should be put to lower intensity monitoring programs such as the use of electronic clinical quality measures, so you make sure that they don't drop off, but then you can move on to those new targets. If we could do this and reproduce this over the next 10 years, we would take a giant step forward with quality in this country. And lastly, as we think about the measures that are going into future value-based purchasing, I think we need to really scrutinize outcome measures more. Everyone says we're interested in outcomes. That's what matters. That's what matters to me as a doctor, and I'm a patient as well. That's what matters. But what we're talking about here are measures. Some outcome measures can differentiate high-quality providers and drive improvement. For example, complication rates and mortality after procedures, bypass surgery. If you look at what the Society of Thoracic Surgeons have done, it's really remarkable. The measures that they have used, the way they have set this up as a collaborative, continually trying to improve quality of care, that's ideal. But many of the outcome measures that we have right now are nowhere near that. They have serious threats to validity, inadequate risk adjustment, and they're very unlikely to improve quality of care. So 30-day mortality rate for acute myocardial infarction, those were some of those measures that we showed that got topped out and retired. In other words, everything that we know scientifically for improving care, or the main things, we've already done. So if I'm a hospital and I'm an outlier on a 30-day mortality rate, what else am I going to do? We don't really know. For chronic obstructive pulmonary disease, if you look at the literature, there's almost no interventions that improve mortality. What am I going to do as the head of a hospital to address that? And my personal, or my least favorite, is the stroke measures for 30-day mortality. There's nothing that improves 30-day mortality for stroke except taking patients who probably should be allowed to die peacefully and respect their right to die, and keep them alive for 30 days. So we really worry a lot about unintended consequences, right? Let's be honest. There are many of these patients who have a stroke. They're 85 years old. They've had a devastating stroke. And what they really want and what their family wants is to be able to die at home with their family around them. Are we going to end up trying to keep some of those people alive to reduce our 30-day mortality rate for stroke? So we need stricter criteria to use outcomes in value-based purchasing, and again, ideally measures that we can really use to help drive improvement. So I will stop my remarks there and say I really think that we obviously have the responsibility, CMS has a responsibility for purchasing value, but we have an incredible opportunity as well through value-based purchasing to drive quality improvement. Thank you.
Well, good morning. Alan's introduction was really quite perfect in terms of thinking about the disconnect that currently exists between what we're doing and how we're measured. For example, in my organization, we have about 25 million annual encounters, and we're using that big data to produce real-time statistical analysis, develop predictive analytics in important areas such as sepsis that are much easier to manage and much more accurate for measurement. In fact, we just closed a 666,000 patient one-year comparative effectiveness trial. Yet at the same time, we're using measures that really are artifactual and not getting at either the sensitivity, specificity, or predictiveness that I think we have accessible to us in the current environment. And what I think is exciting is that good principles of measurement apply whether we're in a more traditional fee-for-service environment or whether, in fact, we're moving to value. And with that in mind, really, I'm a fan of measurement. When I had the privilege of leading the VA health system, I developed the measures for performance improvement in the late 90s. But I think the good science applies whether you're using traditional analytics or advanced analytics such as we have today. And so with that in mind, I usually an optimist and go 16 examples of disconnects between science and what we're doing. So measures clearly do drive behavior change, and we'll see momentarily whether that's desired change or not. Good measures are, in fact, should be based on evidence for a recommendation, as well as evidence for the measure itself, and measurements need to be fit for purpose. There should be measures to which one is not held accountable that are used for institutional or national learning. There should be measures for organizational improvement, and there should be really high bar measures that are available for accountability. So I just, again, the disclaimer, big fan of measurement, important issues, but when the measures actually don't value the science, then we're getting in the way of what we really want to achieve, and that's really better health, better care, better value. So every one of the next 16 examples, which we'll just run through lightning fast, is prefaced with measures should be. So I believe that measures should be about patient care and quality. As David just said quite elegantly, they're imperfect proxies for quality. And outcomes are great when you can get them, but there's a role for process measurement as well. I'd make 2 points. First, depending on the frame of reference, the frame of reference is the effectiveness of delivery system. It is an outcome for the delivery system. Second, you don't have to risk adjust. And third, think about how much we take process measures for granted more broadly in society. We don't ticket people for dying in a car crash. We ticket them for the process measure of not wearing the seatbelt. An example here of this is the efficiency measure, and just as David said, couldn't have teed this up better. It's not clear that the spending per beneficiary correlates for a number of the A and B measures with the quality of care. That's interesting data. I think we should have it. I'm just not sure it's about quality, so let's bill it as what we're asking. So measures should obviously measure something the provider has control over. Not only is it frustrating to be accountable for something that's not under your influence, but it doesn't really solve the issue. When we've looked across our system and we've looked at the health services research, hospitals clearly have inordinate influence in the first 7 to 10 days, possibly out to 30, but goodness gracious, by 90, anything else could occur. Measures should really allow continuous performance improvement, and so timely feedback is imperative. And in fact, if you look at the readmissions data or the mortality data, my goodness, it goes from -12 to -4 quarters. This is just extraordinary. I mean, this is like driving down Pennsylvania Avenue, steering in your rearview mirror based on what you saw 4 blocks ago. It's really dangerous to be here at 15th Street kind of attending to what happened up on 19th. But that's what we're being asked to do right now with some of these very lagging measures. Measures to have rational financial incentives and certainly not cause double jeopardy. And that makes sense. For example, if a hospital with a very low rate of infection, and let me just be really clear on this, I believe the rate of avoidable harm should be 0. But with that in mind, if one is actually observing a standardized infection ratio where the observed infections are less than expected, and that still is the lower quartile by virtue of compression, it doesn't totally make sense. This also applies in a value framework. Our own organization is experiencing some challenge because we've had a national sepsis initiative based on predictive analytics, and the fact that patients are surviving means they have a higher rate of post-acute care. I want them to have that post-acute care. I want them to welcome in the next year with their family. But this is a challenge, and it applies fee-for-service or value. There should be a strong evidence base for the recommendations. Measures are meant to elicit a change of behavior. We've seen this with things like enrollment for Portal. I think that's a good thing. I chair the standards committee. I want to see all patients enrolled in access to their electronic information. But I don't know what the evidence base for that measure is, for example. I suggest that when we look at measures, we ought to look at the evidence that supports the measure and use something like the Preventive Services Task Force. A, definitely good, B, probably good, C, equivocal, or D, probably not good, or I, insufficient evidence. And this was really demonstrated well with the prostate cancer screening that used to be a part of more, particularly the commercial payer metrics. That there should be strong evidence for the metrics themselves. There should be validated and tested as reliable, and done so in the mode of administration. The goal of the emergency room throughput measure was to make sure patients didn't languish in the emergency room. Okay, the math was really simple on paper. Time of discharge from the time of admission to the definitive unit minus the time of discharge to the emergency room equals a number as low as possible. Well, what if that patient is a trauma patient? They come into the ER, they don't discharge from the emergency department, they go straight to surgery where they're admitted. Well, then you get a negative number. The electronic didn't contemplate that, and so those places that were actually doing the very best were confounded by a measure that didn't make sense. Benefit of measurement should exceed the cost of measurement. I'll just use the sepsis algorithm. It's a 9-page algorithm. We're actually working with the CDC in a national study to better define the physiologic markers and attributes of sepsis, but I would suggest that this exercise actually takes the attention away from the performance and to the measurement. Measures ideally electronic if possible. Measures should avoid unintended consequences, and I think we saw this with the pneumonia measure, one of the core measures for antibiotics within 4 hours. Makes sense if the patient came in labeled, I have pneumonia. Unfortunately, patients with respiratory distress may have viral crud, they may have heart failure, may have COPD or emphysema, and all of those situations inadvertently got. So the measure was incredibly well intended, but the science just didn't bear out that it would drive the correct behaviors. Right now we have a national debate about the opioid crisis epidemic really being at odds with an HCAHPS measure, which is really well intended to manage pain. Be interesting to see. I know that physicians that are measured by this are very sensitive to wanting to have superior evaluations, particularly if their institutions, in the interest of transparency, publishes those. So they feel bound, and I think more realistically, the pain community is really considering how do you manage pain, how do you communicate patients effective management of pain, but the expectation, the reality may not be 100% freedom from pain. Ideally, measures should support coordination of services, alignment and systemness, and Part A and Part B PQRS measures in the current environment and the future are not totally in alignment, and David spoke to that eloquently. We're really excited about the prospect of bundles, achieving that, and MACRA, but again, would apply all of the other elements of good measure science. I mentioned before the challenge that you don't want to take the effort from the action of improvement to the reporting. Let's have some common sets of measures, harmonization, measures that are similar, are not identical. And everyone may agree that we should have a beta blocker after an ST elevation heart attack, but 11 different ways of measuring that diverts, again, from the purpose, which is really better care. This plays out in a couple of measures where there are different numerators and denominators. They should reveal meaningful differences in performance. Extraordinary low-frequency events really don't respond well to being denominated or reported as ratios. In fact, for some of the events that are 1 in 10,000 to 1 in a million or 1 in 10 million, when you do that, there's absolutely no predictiveness between what occurs in one quarter and what occurs in the next quarter. I see my Harvard colleagues up here shaking their head, nodding their heads, and indeed Rich Platt and others have demonstrated a lack of predictiveness. It's no more predictive than if an airline has an accident, absent a systematic safety issue, it's not predictive that that's the least safe. In fact, the evidence in that instance is it may be the most safe. A tenth of a point difference may be the difference between 2-star and 3-star. And so we need to be able to articulate what the differences are with a level of meaning. Methodology should be transparent, published, and reproducible by the entities that are seeking to improve. Otherwise, they don't have the tools to improve. And black box risk-adjusted algorithms, particularly used in commercial sector, are problematic. And hospitals, for example, don't have the pre- and post-hospital data that would allow them to better attend to things like readmission. There is a variety of measures that are difficult to understand. PSI 90 is difficult to understand in the professional community. Imagine explaining that to your mother. Imagine explaining how the PSI 90 changed year over year. These are great pieces, but we need to be able to articulate what the differences are in terms of what measures can explain and what they can't explain. A risk-adjusted mortality based on heart attack, heart failure, pneumonia, stroke, COPD, and CABG may or may not be predictive for cancer mortality in that particular institution. Really endorse that there be a national framework for measurement and reporting. There is, as you know, a cacophony, and this cacophony of re-reporting of measures is often predicated on bad math. 2x of this, 1x of that, and divided by something else. I'm not really sure what it means. Health is really important. And I think somehow we've begun to believe that the aggregate of personal measures equal population health measures. Can we really describe cardiovascular disease burden or cardiovascular health status on the basis of the aggregate of all of the AMI measures? Probably not. We need to focus on that specifically. Finally, that validated measures be used for accountability for all the reasons that I mentioned at the outset. The excess days, for example, is an accountability measure, but I have no idea if one emergency room visit is worth half a day, observation stay, a day of penalty in terms of excess days. It is what it is. It's just not the strongest science. So let me close by endorsing performance measurement. It served the institutions I've worked with extraordinarily well in terms of improvement. It drives behavior change, but good measurement in value or fee for service has to be based on good science for the recommendation, good evidence for the measure, in whatever mode it's administered, and good math. Measures have to be suitable per purpose. There's a need for measures that are used for learning. There are need for measures that are used internally for improvement, and measures that are appropriate for accountability. In the immortal words of Albert Einstein, not everything that counts is measured, and not everything that's measured counts. If that's good guidance for measurement, I think the broader picture is really this. Every time we measure something, this is what guides me. The fact that the numerators and denominators are not math, they're real people. Thanks very much.
Good morning. So in the interest of full disclosure, I was involved in the development of the original hospital value-based purchasing plan, so I guess I get to take a second chance at it here. So I'm going to channel a number of the remarks that have already been made, and I'm going to start by talking about, whoops, in the wrong direction. Some of the accomplishments. So I think it is important to pause and take stock of the fact that hospitals have made tremendous investments in trying to work to improve quality over the last decade. And I want to begin by talking about that impact, and then I'm going to transition into talking about some of the areas where I think this program could be strengthened moving forward. So let's see. I think there's a missing slide here. Actually, these slides are not in the right order. All right. Actually, I'm going to get my notes. Sorry about that. We're having some technical difficulties. So what I'd like to start with, as I mentioned, is some of the accomplishments of this program. And I think, as has already been mentioned, is we've seen dramatic increases in adherence to the process measures. So between 2006 and 2012, many of these processes of care measures had achieved 95% or higher. And these process measures were based on evidence about the right things that hospitals and physicians should be doing for patients. So I think from a patient's perspective, that is an actual accomplishment, a victory. And I know that there have been a lot of questions on the street about, is there a relationship between actually improving these processes for patients and outcomes? And several studies have been done and really didn't show much. However, I worked on a project over the past couple of years looking at the impact of the use of these performance measures by CMS. And this work was published in the 2015 National Impact Assessment. And we actually found in the hospital setting for 9 out of 10 process measures that there was a clear link between process and improved outcomes in terms of reduced mortality and 30-day complication rates. And I would direct you to that report. The other thing that I want to note, and I'm in the midst of doing interviews with hospitals around the country as part of the 2018 CMS Impact Assessment work, and we're trying to understand what kinds of changes hospitals have made in response to this program, what challenges they face, and what are the opportunities moving forward. And this will be combined with a national survey of about 2,000 hospitals nationwide. And that work will be reported out in about a year's time. But some of the information that I'm hearing in these interviews is that, hospitals really have made significant changes across many of these areas. And several of the speakers have already mentioned some of the challenges around moving the dial on mortality, but they clearly have made changes that have impacted infection rates. They've actually made improvements that improve the patient experience during the stay. Some examples include not ignoring call lights, doing hourly rounding of patients by the nurse, identifying complaints early on during the admission, and dealing with those in real time. And I think hospitals do feel like these things have benefited patients. But I think there are still some opportunities to move this program in the right direction, and these hospitals have identified some of those already in terms of these interviews. And one of the areas that they've called out is this issue of potential mismeasurement. These hospitals are very heterogeneous in terms of the patient populations that they serve. And there is work going on by the Assistant Secretary to try to understand the effects of socioeconomic differences across all of the CMS measurement programs. And that information will be released later this year. But I would call out, and it's not just exclusive to the hospital value value-based purchasing program, but to all of CMS measurement programs, that we need to be careful about mismeasuring quality. And by that I mean there are a number of things that are outside the control of providers that affect the outcomes of interest. And we need to make sure that mismeasurement's not happening and that we risk adjust where appropriate for these differences in the socioeconomic status of the patients that they treat that impact that outcome of interest. If we don't, we will end up creating some of these undesired effects in terms of hospitals trying to avoid these challenging patient populations. And I think that's not something any of us want to see. Let me see if I can move forward. So I think we're now back on track with my slides. Sorry about that. And I think many of us have had this concern that adjusting is somehow or other going to wipe out these differences between hospitals that are real. And if you look at the measurement science, there's an opportunity here to remove these within hospital differences in performance while still preserving the between hospital differences, or those true differences in quality. And I think that is something we want to aim for, to try to improve the measurement. The other thing that I want to note is while we have this label, hospital value-based purchasing, we are not yet measuring value. And I think the challenge in this space right now is we don't actually have good measures of value. We kind of have a construct that we define as outcomes relative to cost, but we don't really understand how to do that, not just specific to hospital value-based purchasing, but all types of performance measurement programs. What we really have is a weighted combination of quality and these resource use measures at this stage. And but yet there's this, push for greater value in healthcare, and that's based on a belief that there are inefficiencies in the system. And as we think about efficiency, this is really looking at the relationship between a specific product of the health system, this output, and the resources used to create that product, so those inputs, the total cost. And I think we all have this expectation that providers should produce the highest value for any given level of spending. And we know that for any given level of spending, increasing the efficiency will increase value. So if you were to think about the measure that's actually in hospital value-based purchasing today, this is really a utilization measure. It's measuring the relative use of resources 3 days prior, the hospitalization, and 30 days post. And I really ask you to think carefully about what is the outcome of interest that we all care about. And I would assert that that is the quality that is produced. And I would be looking to transition this measure to the hospital's relative efficiency in producing a level of quality for a given spend. And we can do this by estimating the production frontier. And I'm sorry, I'm going to get a little mathy here. So if you look on the horizontal axis, we have two providers, A and B, and they're both producing the same level of quality for different costs. And this curve represents the maximum level of efficiency that could be achieved at different levels of cost. And what we really want to do is get each of those providers closer to that curve. And we can actually measure the relative efficiency with which they're producing quality at those different costs. And I think that this is something that CMS should consider moving forward to try to understand better this cost-quality relationship, because I think it will produce some insights and may provide some opportunities about where to identify opportunities to reduce inefficiencies moving forward. The other thing that I would like to call out in the measurement space is I do think that this program should be moving more aggressively towards capturing patient-reported outcomes. And this graphic is from the National Health Service in the United Kingdom, where they actually report the PROMS measures for certain procedures in terms of hip, knee replacement. And I think that this would be beneficial for clinicians to really understand the types of outcomes their patients are achieving, as well as consumers. And I think this is really the meaningful information for consumers to use when thinking about where to get care. As has been noted earlier, this relationship between cost and quality, a number of articles have highlighted that it's relatively weak. I did sort of a quick correlation analysis between the different domains that are in the hospital value-based purchasing program. So you have clinical process, the HCAHPS, outcomes, and efficiency. And you can see the strongest correlation is between clinical process and HCAHPS, that 0.502. And then between the measure of efficiency and HCAHPS. I also looked at the correlation between these different dimensions and the actual payment adjustment that was made. And what you see here is a very high correlation between doing well on HCAHPS as well as on the efficiency measure. And this issue was recently called out in a Health Affairs article that highlighted the problem that the hospital value-based purchasing program actually made payouts to low-quality providers. And I think as we think about paying for low cost, there's this risk that we are going to pay for low quality depending on how we structure the payout. And if we pay for low cost, we may end up creating other unintended effects because these low-cost providers tend to be those who disproportionately serve these low-income populations, and they tend to have fewer resources to treat these patients who we know cost more to manage. And work that I'm doing in California looking at efficiency and value and cost and quality shows that there may need to be some level of spending to get to quality. And I think we need to carefully think about that as we think about, how much downward pressure to put on cost. And lastly, just to close out, related to changing up this payment structure, we have a heterogeneous group of providers out there. And I think that we have to think about whether in the payment structure we want to emphasize different things at different points. So the alternative I've put up here for people to consider is that below some benchmark of quality, Q, then the program might think about just focusing on rewarding quality to get those providers up to the level that we think is appropriate. And as quality improves, we can transition those providers over to rewarding both quality and efficiency or cost. And among those providers who are high quality, we could potentially use relative efficiency to differentially reward those who are at the top, providing some type of bonus for those who are good stewards of resources as well as achieve high quality. Thank you.
Well, that was a great kickoff to the topic. I'm just going to ask a couple of questions to get us going here. I'm struck at the outset that if we don't have a precise definition of value, but we loosely think of it as quality outcomes divided by resource use, and we want to reward value by giving people money, that adds to the denominator of cost and therefore reduces value. So if you pay for value, you actually reduce value. So how do we think about the improvement imperative here? Can we be a little bit more creative in rewarding value other than throwing dollars at those who are using the fewest resources so that they use more resources, which doesn't seem like what our goal should be? How do we think about this? Who wants to offer up an idea?
All right. So my sense is that providers aren't going to make the changes we want them to make because without having some opportunity for reward, because at least what I've observed both on the physician side as well as the hospital side, they have to make substantial investments, whether that's hiring additional staff to target the areas, changing up certain structures, whether that's buying equipment, investing more heavily in certain health IT components. So the kinds of changes or transformations we're asking providers to make, it doesn't come at zero cost. And so I do think that, we need to signal the behavior we want, and then we need to provide some resources to support them doing that work.
So does that argue for financial incentives directed more at improvement, which is the investment, as opposed to level? I'm just trying to get the implications of that.
Well, I personally have always supported you should pay for improvement because I think that helps providers all along the continuum. Because if you set your targets high, I understand this concept of paying people at the top because it really pushes people to a high level of achievement. But many providers, depending on any given measure, may be very far away from that target, and yet we're still asking them to make considerable investments to get there. And so the question for them is, how can they convince their leadership to make those investments when there will be no payback?
David, do you want to? And then John.
I agree with what Cheryl said. I just want to emphasize one thing, particularly for some of the safety net hospitals. The payments are going to come too late to be able to fund the infrastructure that they need to improve quality. So they need more upfront payments to be able to improve their infrastructure, and to have the payments or the promise of potential payments when they don't know whether they're going to improve or how long it will take to improve, I think is really problematic. So I really agree with what Cheryl was saying. We need to think about this differently depending upon where hospitals are across the spectrum of quality and cost, as well as what their resources are.
I'd address your comment in two ways. I mean, the first is getting back to first principles. What is the problem you're trying to solve? And I think some of the problems really relate to, in the clinical sense, to the fragmentation and creating coordination of services. We know that there are avoidable breaches of safety that can be improved. We know that quality can be better. And so I think there is utility in going after those things somewhat discreetly. I think we also understand that the sustainability of our health system is under a great deal of pressure, and we have to address cost. I'm just not sure that we have the total model to put those together yet to be able to do that. To the second point, in terms of thinking about quality or performance and improvement, it was interesting. When I was at VA, we used to have a paradigm where we had quadrants of performance on one axis and improvement on the other. And a large increment for a low performer was worth the same as a small increment for a high performer. That way, as you got toward perfection, those increments are really difficult to achieve. And this level of performance down here, unacceptable. So I think there are ways in which we can look at frontiers in terms of efficiency and performance and triangulate to really a more coordinated look at both the efficiency as well as the other parameters of care outputs.
Let me just bring in another topic. Cheryl, you focused at the end on risk adjustment. And Jonathan, I think of the 16 points you made, the notion of measures should be things under the control of the people you're measuring sort of falls into the category of where do we put the characteristics of the patient population. I know there's been a lot of debate about the role of risk adjustment and its appropriateness, but I sort of want to step back and ask almost a more technical question, because we had a lot of experience thinking about risk adjustment with respect to insurance rates, and it's always sort of this black box. It's like, oh yeah, all of that will be solved by having good risk adjustment, and we just can't do it that perfectly. So I guess my question is, in the overall thinking about how to address performance measures, are we far enough along in even our understanding of the role of those patient characteristics to do effective risk adjustment that could improve our measurement of performance and value? I'm sort of asking more the technical side than the ideological side of whether different institutions should be held to different standards.
Well, it's dependent on having information on these characteristics of patients. I will say this, I am working on a project for CMS on the Medicare Advantage side, and we've spent the better part of the last year really trying to dissect the role of socioeconomic status in terms of these within health plan differences in quality performance. And based on that work, Medicare has decided to move forward and do adjustment of these clinical measures, starting with this plan rating year, which they call the plan rating year 2017, because it informs choices for 2017. I actually do think that we have the ability to do this risk adjustment. It requires patient-level data. So as you know, the measure stewards and the people who are running these programs think about this, you would have to have access to that information. But you know, it's clearly doable. And you know, the first step in all of this is to look at any given measure and understand, are there disparities? Because in certain cases, we found measures had what I call positive disparities. So it's not always negative. And I think you need to do some targeting and thinking through kind of the conceptual basis for why providers may be having more challenges with a given measure with a particular population.
John?
I think Cheryl's answer is brilliant. You have to have the patient-level data to do really substantial risk adjustment. In the absence of that, I think you know, what we knew 20 years ago, Lisa Hizoni's publications indicate that you can only explain 20, maybe at the extreme, 30% of the variation. That said, this is why I think we're at such a critical inflection point and have this extraordinary opportunity. What is that? That is the ability to transcend deriving or trying to do this from the administrative data, and instead using what I refer to lovingly as the data dividend of meaningful use. We have this data exhaust of every clinical encounter now thanks to meaningful use. And thanks to standardization, increasingly there are incredible troves of structured data that are readily computable. And the opportunity to really capture those data can take us to another level of sensitivity for really explanatory risk adjustment and better insight into clinical process and outcomes.
I have to raise a caution, though, as exciting as that is, that there are major parts of the healthcare sector and certainly the social sector that aren't wired that way, and our collection of socio-demographic data is really, in the healthcare sector, pretty spotty. So I think on the clinical side, you've got a whole new source instead of administrative data, but the SES side is a little tougher.
Well, I think that's an incredibly important point, because the other challenge with that we have is that we take an awfully ethnocentric view of where health, disease, and care occur, and it's not restricted to the four walls of our institutions. That said, within our institutions, the data are that for hospitals after meaningful use, really well over 95% of the hospitals are well past stage one. I think the tide has raised all ships: critical access, rural, small, urban, safety net, large, community, et cetera, all are there. We're well above 70-75% of physician practices, and so you do have those data. I think, to your point, there is a need for more of the socio-demographic data that clearly is explanatory. And when you talk about the patient-reported outcomes, we need to begin to be able to tap into those other resources, everything from the sensors that we all ubiquitously wear, our smartphones, et cetera, that provide another level of what really are clinical data and functional data that lets us get at another aspect of the outcomes we seek.
David?
So in answer to the first question, do we have good risk adjustment models for these conditions? And I was able to work with the Cleveland Health Quality Choice Program in Northeast Ohio, and we had extremely detailed risk adjustment models for 6 medical conditions, 6 surgical conditions. This was a public reporting program, so twice a year these risk adjusted rates were published in the Plain Dealer, the main paper there. This required extremely detailed chart abstraction of the level of oxygen in the blood and the kidney function and how well the heart was pumping and all of these things. So we have those models. Our ability to get that data out of electronic health records is still a long way away from where we need. So even though the focus is on the socioeconomic status, it's tremendously important, but we're looking at 30-day mortality rate for heart attack without looking how badly the heart was damaged. So, we're not doing some of the most basic things that we know are important predictors. So it's going to have to be a little bit of the chicken and the egg. We need to be able to say we're going to be adjusting for those things, and we need to have better ways of capturing the data within the workflow from the electronic health record so that it's actually valid.
That's great. Shirley?
Yeah, I would say, I realize sort of standardized collection of this information is often lacking among most healthcare providers. But I do think that there are some interim solutions. So to the extent that you have patient-level data, you can certainly map in at the census block level certain characteristics. Those characteristics are very revealing. And I think that they tend to line up pretty well with the existing measures in terms of, percent Medicaid population. So I think we're not starting from square zero. Clearly improvements can be made in what we capture, but, my concern is if we continue to wait, I think all the economic signals right now are really going to put a lot of pressure on these providers who serve low SES patient populations to try to steer clear of these people. And I think that that's not a signal we want to send.
So I'm going to bring one or two questions in from the audience. We have a tight timeline. I'm going to take these two people right on the aisle, and we're going to have to move to the next panel. But let's get a couple of your voices in. Please introduce yourself.
Thank you, Peter Donstedt, obnoxious person. If we look at the concept of value as output divided by the resources consumed, or money, let's just say that, some of the largest drivers of cost overall appear to be pricing by all parties. Drug manufacturers, device manufacturers, that can account for half of the hospital stay. Price increases for physician services or by physicians that are employed by health systems and point service location codes and so forth. Charge master inflation and the subsequent impact on outliers. What it can drive there. And we can go on, and I'm not trying to tar any one particular sector here. But I don't see where we're calculus anywhere, and that's not where we can't, but is there any place where we do account for it, and can we calculus more in future designs?
Who wants to take that on?
So I'm not going to talk specifically about hospital VBP right now. I'm going to talk about my work in terms of value-based purchasing on the provider side. So I'm working on this evaluation of the Integrated Healthcare Association's value-based pay-for-performance program in California, which targets roughly 200 large physician organizations in the state. And they are holding these organizations accountable for total cost of care. And my sense is kind of this near-term reality for us is these very blunt measures, right? And they send kind of an overarching signal, and then they really, turn it over to the provider to figure out where they can achieve, greater cost savings. So, that may come through different purchasing, different negotiating with their vendors as one means of savings. However, I have to say, in doing a lot of interviews in California, I've yet to hear anyone mention that as a way that they're trying to save money. The primary focus right now is keeping people out of the hospital. And if they get into the hospital, it's managing that throughput more efficiently. So, you don't wait 2 days to get your CAT scan. You've got a hospitalist who's really dogging, the people within the facility to make sure that CAT scan happens same day or next day. But I agree. I think we lack precision in our ability of what our targets are for reducing inefficiencies in the system. And I think that really should be an area for development of measures.
Let's take one more and quick question and answer.
Thank you. Marion Grant from the CTAC Coalition to Transform Advanced Care. I wonder how you would comment about the potential contradiction we're going to have between standardized measurement, which makes, of course, a lot of sense, and person-centered care. Obviously, at CTAC, we're focused on patients with advanced illness, and as Dr. Perlin pointed out, 30-day mortality post-surgery or post-stroke is perhaps contradictory to what the goals of care are going to be for that patient population. But even stepping further back, somebody with advanced heart failure might opt out of routine mammogram screening or tight blood glucose control. So how are we going to balance those two important measures while we all talk about moving to person-centered care?
Thanks. I think that's a terrific question, and it's one that will come into play even more as we're moving into the era of personalized and precision medicine. And so I think we're going to likely have to parse our measurement and focus into those things that are generally applicable and those things that are adherent to the personalized or the precise nature of the care needs of the individual. And when I say personalized or precise, I'm not just inferring omics. I'm inferring preference and other desired functional outcomes, et cetera. So I think our measure set has to be more sensitive, not just to the things that we ethnocentrically, clinically, administratively think we want, but those things that the patients tell us. I'll just leave with one note. When I think of measures in the future, I think of all the things that we're doing in this frame, and then I look at my kids who assess everything on the basis of Yelp. So there is a different environment in the social environment that will provide a totally different set of ratings, and it's much more finely attuned to patient or consumer interests.
And we had a paper on that very topic in the last issue of Health Affairs. Yeah, Dave.
I just wanted to say, prior to coming to the Joint Commission, I was Chief of General Medicine at Northwestern University, and in our general medicine clinic, we actually, within the electronic health record, had fields where the physician could say that the patient had declined, after, really going through proper explanations. The physician could also put that there was a medical contraindication, or, for these patients who had multiple complex illnesses, and say, I don't want to add in their 13th medication for this. So I think that that's helpful. We still, in my experience, need to accept the fact that patients have the right to refuse. There's a lot of debate of saying, well, some doctors are good at explaining and some aren't. Well, you can look at that in the data as well and see if there are outliers. So I think capturing that information with the electronic health record is possible.
Well, I think this has been a great introduction both to where we are with hospital value-based payment, but also to some of the broader issues just in paying for value. Please join me in thanking our panel. So we're going to move directly to the next panel. We do have seats, as always, up front, so I would encourage those who are standing to come on in. You pay the penalty for not being here on time by having to sit up front. Okay, I'm going to keep us moving. We lost a couple of minutes with a late start, and I just think the content is so robust, I don't want to cut into the time. We're as we make the transition, we're going to move into a discussion of the value-based payment issues in the physician context. Of course, we're at a very dynamic moment, might be an understatement with respect to where Medicare is in thinking about physician payment. And so we have the next group will focus here. We're going to hear from Meredith Rosenthal, Professor of Health Economics and Policy and Associate Dean of Diversity at the Harvard T.H. Chan School of Public Health. We'll hear from Dana Gelb-Safran, Senior Vice President for Performance and Improvement, Blue Cross Blue Shield Massachusetts, who oversees quite a number of performance initiatives and is a frequent speaker on a topic that we've published extensively about in Health Affairs, the alternative quality contract used by Blue Cross Blue Shield of Massachusetts. We'll hear from Alan Lazaroff, member of the American Geriatric Society Board of Directors and a physician champion at Pioneer ACO Physician Health Partners. And we will hear from Tom Valek, a partner at Discern Health, which he joined after a tenure at the National Quality Forum and Senior Advisor and Medical Officer at CMS. So we have a number of different perspectives on the world of value-based payment in the physician context, and I'm going to turn it first to Meredith.
Thanks, Alan. It's a pleasure to be here today. And so for all that one can say about hospital value-based purchasing, there is oh so much less to say about physician value-based purchasing. And I took a relatively narrow scope on this, particularly since I am sitting next to the accomplished Dr. Safran. So I'm not going to talk about health systems really at all, or the ACO level, just really the physician level. And I was also forbidden to give details about the current programs, but that's good because I think we know very little about them. So as you know, healthcare value-based purchasing has been going on probably for 30 years in the context of Medicare, but at least in the last decade, there has been this considerable acceleration and expansion of value-based purchasing. And I have my own sort of favorite set of program steps when I think about this, and so in terms of the pathway, we've seen hospital compare, nursing home compare, collection of data on surgical outcomes as well, and publication of those data, typically followed by demonstration programs. A couple that come to mind that have been important in informing how we think about physician value-based purchasing and hospital value-based purchasing include Premier and the PGP demonstration, but of course neither of those was about paying or measuring quality, value at the individual physician level. And since then, we have seen a broadening of programs to cover ACOs and bundle payment. And much more recently, the unfolding of physician value-based purchasing, in part predating the Affordable Care Act, but most significantly, the value-based payment modifier that I won't address directly, but one can look over the last 20 years of Medicare history and sort of see that there has been a pattern of a relatively narrow focus, for example, starting with cardiac surgery, broadening over time to more comprehensive measure sets, more comprehensive pieces of the delivery system, followed by demonstrations. And the initial focus really in value-based purchasing was very much on quality, with costs to come at a later time with less emphasis, and really going from low-powered, we're collecting data for you, we're collecting data for consumers, then we're attaching dollars to it, moving to higher-powered notions. This pattern that seems to be stepwise has really not played out for physician value-based purchasing. The physician quality reporting system and the value-based payment modifier were sort of the two predecessor programs for physicians in terms of value-based purchasing, and both were effectively ignorable and thus largely ignored, except by some larger systems where the cost of entry was reasonable relative to the opportunity to get to practice what value-based purchasing might look like. And we have not had demonstrations within Medicare of physician pay for performance per se as we look across the efforts both in the U.S. among private payers. Cheryl mentioned the IHA, as well as in our neighbors across the pond. There's very little that one can say that we've learned about physician value-based purchasing that would be a takeaway that would lead you to decide that this was the right time to add this aspect to the Medicare program. We have almost nothing but null and negative results when it comes to individual level physician quality and cost incentives. So with the current program, what we have instead is all at once, Medicare is rolling into the present with a public reporting program as well as a pay-for-performance program that covers not only quality but also cost, as well as some what I might think about as participation measures. So it's hard to tell precisely what the goal of this program might be. One could say that that this is just a pay cut. So the current program will affect ultimately pay by plus or minus 9%. And some physicians that I've heard from in Massachusetts at least are wondering whether that's just money that's going to be left on the table. On the other hand, this may be an effort to get physicians to be part of a larger entity where measurement and reporting, again, is more cost effective. The notion of quality improvement at a larger entity, it makes more sense. But then I think we'll get back to some of these conversations around prices and whether pushing physicians to be part of larger entities for the purposes of Medicare payment will cause higher prices on the commercially insured side as a result of continued consolidation, which we've already seen. And then finally, the payment model does have a safety valve, which is that if one is participating in an alternative payment model, then all bets are off. And so this may be really important. And not to take too negative a view of this, but in fact, I think many people have said, well, ACOs are great, but it's opt-in, and the status quo is still so appealing, particularly for those physicians who deliver procedures, that until we see the status quo become less appealing, then we won't really get full participation in alternative payment models. And so that may, in fact, be one of the most important outcomes of such a program. And unless the program is sufficiently onerous, the status quo remains reasonably appealing. So I wonder then, what we might think about accomplishing through physician value-based purchasing. The problem is ultimately there is such a strong conceptual problem with thinking about Medicare at arm's length paying individual or even small single specialty groups of physicians that conceptually, not only do we have small sample problems in applying even the best intended quality measures at that level, but conceptually we think about physicians as being part of teams, as part of systems, and we are still looking at individual processes of care, and so it seems like one of the biggest opportunities here is to maybe rethink a little bit, what is it that we want physicians to do? Surely it's not one screening test at a time, but to be better aligned with a system that is focused on something like population health and focused on value, which does not, for example, mean holding physicians accountable for readmissions, but instead understanding what physicians contribute to that problem, what they can do to be part of a solution to that problem. And so the payment models that we might think about should perhaps focus more on alignment in two ways. One, alignment with the rest of the delivery system, including a health system, including independent hospitals, so that physicians are sort of part of an overall solution to the most important problems that patients face. And second is to think about alignment regionally. We have this model now where physicians may choose quality measures as part of this program. Would that not be strengthened if there were regional norms around what quality issues we're going to work on? So even where physicians are independent and being measured separately, there could be collaboration on quality improvement, and again, a focus on what the local needs are. So I leave you with some possibilities. It's a little bit hard to know exactly what will come of the current programs, as opposed to thinking about how they might better align with more holistic notions of payment and delivery system reform. Thank you.
Good morning. So I'd like to start by thanking Health Affairs and the Federation of American Hospitals and the other sponsors for convening us for this really important and timely conversation. I have 3 goals in my brief set of remarks here. The first is to share with you a little bit about what the motivation was back in 2007 for Blue Cross Blue Shield of Massachusetts to introduce the alternative quality contract. Then to say a few words about results, and including how it's changed the market in some ways I think are relevant to the conversation we're having, and results for patients. And then finally, if there's time, to say a little bit about where I hope that performance measurement is going in light of the payment reform that we're seeing take hold nationally. Now, let me be clear. Can I have my slides, please? Oh, do I do that? Great.
Should be.
So just to be clear, the information that I'm going to share with you is not about individual physician payment, but rather payment to physician organizations. That's a very important distinction, and I'm sure we'll get into a lot of that in our discussion. But in 2007, Massachusetts was in the very early months of implementing our now quite famous coverage reform law that became the template for the ACA. And what drove Massachusetts, Blue Cross Massachusetts, to undertake payment reform had a lot to do with the fact that we now had solved, or were on a path to solving the issues of coverage, and we knew that cost was next. And in fact, we knew that cost was next for lots of reasons, but among them, with large numbers of individuals for the first time buying coverage for themselves, they were going to come face to face with the real rate of rise of healthcare costs and healthcare spending and be rightly outraged. So what I'm showing you on this slide, the blue line is our real Blue Cross of Massachusetts medical cost trend over a period of time from 2000 through 2009. So you can see where we sat in 2007, looking back over double digits for years. I can tell you, apropos of a question that got asked in the previous panel, that roughly half of that was price and price increases, and the other half was just a relentless increase in use of services and toward more expensive sites of service, more use of inpatient care, more use of academic medical center for basic procedures and so forth. So double-digit rates of rise, and contrast that with the green line, which is general economic growth, and the red line, which is wage growth. And we knew that there would be a very significant public conversation. There has been. So the Alternative Quality Contract, or AQC, for those who aren't familiar with it, is a global population-based budget model that has a significant set of quality and outcome measures coupled with it in order to provide very significant earning opportunity on quality and outcomes for the population. Provider organizations that come into the model are accountable for care across the full continuum, from prenatal care to end-of-life care, total cost of care for their population with upside and downside risk, and with these significant earning opportunities on quality and outcomes. So a few words about results. Here are the results in terms of the uptake in our market. This has so far exceeded anything we expected when we launched the AQC with our first contracts in 2009. At that point, we hoped to get 10 to 15% of our network contracted in this way over the first 2 years. You can see that we had about a third of our network by 2011. We now have over 90% of physicians, both primary care and specialty care, contracted under this global budget payment model. I was asked to say a little bit about what's happened in the way of consolidation, and I think that this slide tells an interesting story along with the next one that I'll share with you. So what you'll notice here is in 2016, over there on the right, there are 6 groups that account for 59% of our membership. what you'll also notice is over in 2009, those 6 groups and the seedlings that came to become part of them accounted for 56% of our membership, but at that point it was 17 organizations. There was quick change. You can see by 2012 we already had the 6 groups, and they already had taken in a lot of those smaller groups. But that overall, from 2012 to 2016, we haven't seen a lot of further consolidation. In fact, the percentage of our membership that's in these 6 groups has declined a little bit, and you can see none of these groups has, since that time, grown in any significant way. One of the things I think is very relevant to the conversation we're here to have today is what about doctors in small or solo practices? So here's what I want to say about that. In Massachusetts, you might be surprised to learn that it has always been the case, it remains the case, that the majority of our network are doctors in small or solo practices, 5 doctors or fewer. However, what has happened over this period of time is that a large share of those doctors that were both small practice and unaffiliated with anything else have moved to become affiliated. And that's what this trend line is showing you. So around 2008, about a quarter of our primary care physicians were both in a small practice and unaffiliated with anything larger. Today, only about 8% of our primary care physicians, about 550 physicians are in small practices and unaffiliated. A very big change. A little bit about outcomes, and then I'll just take a moment to talk about where I hope measurement is going. What's illustrated here come from the ambulatory outcomes side of the AQC measure set. There is also a hospital measurement side. But what I want you to notice from this slide is just a couple things. First, the blue line here represents the changes in performance from before the AQC 2007 through the first 4 years, 2012, for our 2009 cohort, right? The group that came in first and for whom we have the longest period of time to observe. And so you note, and the orange line represents national benchmarks for those same measures. So you notice that there is significant improvement among the AQC groups. You notice that in all cases they're outperforming national benchmarks. And you also notice that the trajectory for adult and pediatric care is actually quite different for reasons we can talk about if you're interested. But the piece I want to really call to your attention, because it's very relevant to our conversation today, is on the right side. That's the health outcomes. In 2007 and 2008, as we were negotiating these contracts to launch in 2009, it was, I thought, audacious of us as a health plan to ask our providers to take accountability for outcomes, particularly not outcomes within the confines of their institution, like hospital outcomes, but health outcomes, control of chronic illness. But we came to the table and we included that on our measure set. And the early adopters of the AQC were visionaries, so they didn't say they couldn't do that. They didn't say that, how can we control what happens when our patient is out living their life? They said, these are the most important measures, and if we could get to your highest levels of performance on these, we would have accomplished something really important for population health. So we triple weighted those measures. And what you see here is that the way that they've succeeded at accomplishing these important population health outcomes, this is keeping some of the most high prevalence, high impact chronic illnesses in our population under good control, which you can see before the AQC and still nationally, we're at a frighteningly low level of ability to do that. Less than 2/3 of adults with chronic illness under good control. They moved that to 74%. And again, that's not one condition and it's not one group. That's a quarter of our network that came in 2009 doing this. So really important things as we move toward accountability for outcomes. What it causes these organizations to do is to reinvent care. If we get a chance during the discussion, we can come back to the socioeconomic status issue, but I'll just throw out a teaser here and say some of the organizations that did this the best were the organizations taking care of the most socioeconomically vulnerable populations. And it's because we got their budgets right and then didn't give them a lower bar on the quality or outcome measures. They had the same bar as everybody else, and they went ahead and outperformed most of the network, including those taking care of much more advantaged populations. I won't go into the cost results. Those have been widely publicized, including by this journal. The results here from the 4-year study published in New England Journal showing how well this model has helped to reduce spending growth. But just a last word on where I hope performance measurement is going given payment reform. So given models whose goals are to improve on cost, quality, and outcomes, what we've put forward through the Healthcare Payment Learning and Action Network population-based payment work group, which I have the privilege to co-chair, is a model out for public comment right now that says we need to, under population-based payment, move toward more outcomes-oriented care, that in fact we can solve some of the cacophony that has existed in measurement that is so concerning and disturbing to most providers and provider organizations, and that's represented at what we call level 3 measurement. Those measures will still be very important, all of those, in fact, process measures, very important for driving improvement, but they don't have to form the basis for our incentive models and our accountability models. Rather, we can move toward bigger dot measures. On cost, of course, we have the perfect big dot measure, the all-encompassing total cost of care measure. We wish we had something equally all-encompassing for quality and health, but barring that, we propose a way to get to big dot measures of health outcomes for important conditions and for cross-cutting issues like disparities in care and access to care and integration of care. So we can come back to that. But that's where I think we need to go in performance measurement, both to solve the burden of measurement, but also, most importantly, to provide real value to patients and to our system. Because if we're rewarding outcomes, then by definition, the dollars that we're spending are actually delivering to us better results. Thanks very much.
Good morning. I am a geriatrician, and I suspect that I can most credibly make the argument that I'm a real clinician compared to all the other speakers, and that is the truth. I live in Colorado and spend much of my time at our cabin at 9,000 feet, and I always worry coming down to sea level whether my brain will run too hot. But the air is indeed pretty rarefied up here for a clinician, so I think we're going to be all right. But as a geriatrician, it didn't take long after entering into that field to realize that there was something wrong with the payment system in the sense that it was virtually impossible to make a living. So if you look at my bio, you will see that I have been involved in multiple alternative payment models for virtually my entire career. And that's the perspective that I bring. And I want to bring things down to the ground level a little bit and focus particularly on primary care in this time. And first, I will say some things about the temperature of primary care physicians in my market and what is happening in that market right now. And primary care physicians have been very supportive of healthcare reform, expecting that healthcare reform would rejuvenate the very weak primary care sector that we have in the United States. But instead, if you ask the typical primary care physician what's happened, they will tell you that there's been a steady and accelerating increase in the expectations placed on them, but the corresponding increase in payment to support those expectations has not materialized. And so I just will comment that being part of a reorganizing industry is a very challenging environment. There is already change fatigue in our community, even though we're just at the beginning, obviously, of this transition. A lot of that is because of the widespread adoption of electronic health records, which is a big success to have achieved that. but most doctors will tell you today that the electronic record has not made it easier for them to take care of their patients and has not enabled them to improve the care of their patients. There are two factors here. One is the usability factor, which was sort of underappreciated or it was not thought about, I guess, enough in the design of these systems. And the other is, I can't remember. Excuse me. But the bottom line of all of this is I have to tell you that the morale in this community of physicians is not good. There's an awful lot of uncertainty. And we're looking at a system where there's a shortage of primary care physicians, and we're trying to build a system that's heavily dependent on the activities of primary care physicians. So just looking at our market, there aren't enough primary care physicians, and market forces have started to take hold there. We have a strong presence of Kaiser, an excellent organization, and what's happened is that in order to attract primary care physicians, they are offering starting salaries that are way beyond what any of the private practice people can offer, and the private practices are unable to recruit any doctors. So the people are retiring, they're not replaced, and there is a clear and seemingly inexorable movement into bigger systems, which has some advantages. I'm not saying one way or the other, but it is inescapable that this is happening. And there's a flight to safety, hospital employment. Health plans now are starting to talk about directly employing physicians in our market. And some of these people will try to escape this entire issue by going into concierge practices or cash-only practices of various types. It's small, but it's real. So now, with the rule that just came out about macro implementation, I know most of you have thoroughly digested all 962 pages, but I still am struggling to do that, but I will make some comments about that. First, it lacks the virtue of simplicity. And this is a problem for it's extraordinarily complicated, and if we have trouble understanding it, imagine what this is like for the typical physicians in the community. We know about MIPS. When the macro law came out, it was publicized as something that was not designed or intended to be a viable long-term answer. It was more like a program to administer progressively increasing doses of castor oil to the physicians until they finally surrendered and did what we wanted them to do. But their actual rule is more than that, because we've got this sort of new category of these MIPS APMs and a lot of room for experimentation and so on. And there's obviously an intent to provide a bridge to the advanced APMs. But for doctors to join an advanced APM, there has to be an advanced APM in their community, and this is going to be a problem, I believe. If you look at the risk side of the APMs, the risk requirements are very tough. There's a clear preference for aggressive risk-taking in the belief that if you put people at huge risk, that's going to promote change better. I think that's problematical. Maybe we can talk about that some more. It's not clear if an ACO can succeed as a standalone organization because of the risk. I think we've done global cap in Medicare Advantage for many years, and my view is that the macro proposal for risk is much greater risk than even global risk in Medicare Advantage, and we can talk about that. The medical home options, the CPCI plus, these will draw a lot of interest among primary care physicians. And I want to spend a minute talking about the critical role of setting benchmarks, because I believe that this has not gotten enough attention. What is the right price for the service? And that's the question, whether it's an office visit or whether it's the care of 30,000 Medicare beneficiaries and a global payment issue. And that's still an issue, and I would say to you that that's really where we started, and we still have that problem, and we haven't really solved that problem. Your success in these programs is determined by your performance, but that's not the only thing that determines it. How the benchmark, how the expectations are set is also critical for that. So let's see, how do I do this? I only have one slide. Okay, there we go. So Physician Health Partners, this is a physician-owned, primary care-driven organization that does IPA network management, 20 years of experience mostly in Medicare Advantage, great success in Medicare Advantage, good success now in Medicaid, success in some of these commercial plans, no success whatsoever in the Pioneer ACO or the MSSP, and I want to talk about that for a second. So we were thrilled to be chosen as a pioneer. This came up very, very quickly. There was no run-up. So we expected to have no impact in the first year. We thought we would be break even. We're just putting our infrastructure in place, hiring care managers, training them, and so on and so forth. So we were stunned to learn that we were in a $9 million loss at the end of the first year, and we could not figure out how that happened. We didn't see the changes, in the utilization and so on. And so we couldn't figure it out. We dropped out. We ultimately went into the Medicare shared savings and so on. And why this happened became clear only later when people started looking at the methodology. And to grossly oversimplify, CMS developed a baseline cost for each ACO depending on the historical cost, so that could be low or high within the same market, across markets, and so on. And then they trended forward for the year using the national growth rate of Medicare costs to see what your target expenditures would be. Seems sensible, but what happened is after external research started to come out and there were comparisons between using the national growth rate and your regional or local growth rate. And when you looked at our performance compared to the regional or local growth rate, we saved $1 million instead of losing $9 million. What it turned out is we were in a below average cost market in Denver. Our costs were significantly lower than our own market, and our growth was no greater during that year and probably less than our own market. But that produced a $9 million loss. How could that be? Because we were in a place with a booming economy, hospital construction all over the place. We faced a different set of challenges than other places in the country. So what this would mean would be if you were in a low-cost market or low-growth market and you tracked your own market, you could make a bonus. And if you were in a market that had a high growth and you tracked your market, you had a loss. And the characteristics of your own market compared to national growth rate largely determined who won and who lost in that. So CMS has addressed this now and has changed this entirely and is going to use regional local growth markets as the comparison as opposed to the national. But it means that as we go forward, nobody has any experience at all in working under this new model, and it will significantly change who wins and who loses. It's an entirely new ballgame. We ought to keep that in mind. One other point about the benchmarking. I know I'm running over the time. Okay, so it's very hard to talk about something as complicated as this is in 7 minutes. One other point. Using the historical benchmark as the starting point. So the commercial ACOs have in our market we have 5 of these, and they've all emulated the CMS methodology. So here's our conversation that we have with the commercial insurers. Gee, we love you guys. You're 20% less expensive than the market. That's great. So our costs are flat. We didn't take much out. The people up here, they took some out, and so they get a big bonus, and we don't get anything. And from our perspective, what's happening is we're the ones saving the money, and they're using the money that we saved to subsidize our competition. And so the doctors are told, well, they don't know PHP, they don't know what they're doing, they can't generate any bonus, so you should come over to us. And there's great pressure. We can't hold the network if this continues. The network will go to other people that have no understanding. So I think I ought to stop. I had some more to talk about, but I appreciate your attention and look forward to further dialogue.
Good morning. So Alan, I was going to start by thanking you for not having any slides, since I didn't want to be the only outlier, and then you popped one up. So, and I'm a consultant. Does anybody know any consultants who don't use slides? I think consultants started us all using slides, and maybe I'm going to start a new trend, which is we're not going to use slides anymore. But I also have the privilege of being the cleanup hitter, which means that not only for this panel focused on physician payment reform, but also the hospital, pretty much everything has been said. So I'm going to start with by way of summary, and that'll allow me, Alan, hopefully to keep things a little bit shorter. But I do need to, as a CMS alum, I do need to start by thanking Patrick Conway and Kate Goodrich and their teams for their very hard work, very thoughtful work in addressing these extremely difficult issues, and the way that they've gone about it with grace, and also with a really strong attempt, as I always tried to do there, to connect with the provider communities. So I think they deserve to be saluted for that, because they have so many things to balance. It's a massive scale, and we are here to critique the programs, but in the spirit of constructive criticism. So my reactions to the MACRA implementation proposed rule. First, I think the biggest issue is actually not the policy. I think the biggest issue has been raised by my colleagues here on the panel, which is the lack of awareness and or buy-in. Meredith referred to this as, what are the goals and what are we really after here? We haven't really demonstrated what we're going to be applying here on a massive scale. We haven't convinced the physicians of why this is important, of what we're going to have to do about it, and engage them in those solutions. And then the how in 962 pages is really going to get lost when you don't buy into the why and the what. And even the CMS administrator has said, I think we've lost them about the meaningful use program, and there have been attempts to move beyond that, but when the agency is admitting failure, given all that the agency does to not have to admit failure, I think that's pretty significant. And we have, over time, been putting the building blocks in place. Mark McClellan told me that was my job in 2004, to start putting the building blocks in place for what we're now seeing these many years later through PQRS, Meaningful Use, Value-Based Payment Modifier. But as Meredith said, these programs have somehow been ignorable, even though there's been an obvious path. So there's denial. People have been waiting for the tipping point, and maybe it's come to that. And the time pressure doesn't help, right? At least they got the rule out in the spring, but to finalize it in the fall for a first performance year, a couple of months, we wish it was a couple years later, and we're going to have a new administration. This is crazy. Are we going to end up with a 90-day performance period like we had when the meaningful use rules were always late? So that's something to keep in mind. So that's, I think, the biggest issue, is just sort of dealing with lack of awareness and the tsunami, if you will, that's coming. I think the most surprising thing to me was the narrow definition of APMs. Now, maybe that isn't surprising when you think about the complexity and when you think about the points that Alan was making about how some of the APMs are working on the front lines. But this really is supposedly the goal, right? To move 50% of Medicare payment to alternative payment models by 2018. I think, get more flexibility under that approach. And so to see a relatively narrow definition there, a little surprising to me. Perhaps the administration just wanting to keep the bar high, not dilute things too soon, to make it too easy to be successful in that environment. Perhaps it's just that the administrative issues are too overwhelming. Perhaps they're really going to be looking to this PTAC, the Physician-Focused Payment Model Technical Advisory Group, to provide these more granular and diverse solutions. Where are some of the bundled payment approaches beyond OCM, for example? We do have high hopes for CPC Plus, but I think that remains to be seen how CMS is going to be expanding the APMs over time. So if that's the most surprising, well, what was the least surprising? Least surprising, I think, is this continued march toward consolidation, and every one of my colleagues commented on it. There's obviously a risk here that's been happening for some time to the small and rural practices. I thought it was very telling that the most read Modern Healthcare article post the MACRA proposed rule being released was titled, "Will Medicare's Physician Payment Overhaul Drive More Docs to Hospitals?" And then Farzad Morstashari came out and said, this is financial suicide for small practices. I hope I'm not taking his quote out of context, because I know that he supports all the administration's work, but he's working with small practices to try to be successful in this environment. So I think Farzad knows a lot about what's happening on the front lines. And then another colleague who I have a lot of respect for, John Halamka, a pretty balanced guy, said, this may sound cynical in a blog, but there are probably only two rational choices for clinicians going forward. Become a salaried employee delivering clinical care, or become a hospital-based clinician exempted from the madness. So this is what we're hearing from some of the respected voices working on the front lines. But in terms of this consolidation, is it inevitable? I guess I want to ask three questions about consolidation. One, is it inevitable because we are in a rapidly evolving world, not just a rapidly evolving healthcare system, and we do need to take better advantage of infrastructure. And different markets are all different, so we have to think about how to make the best in the particular market to get to the right balance. And with the world changing, perhaps the idea of consolidating to take on more risk actually makes some sense. We do have the small physician practice technical assistants, $20 million per year over 5 years. Gosh, that's really a drop in the bucket, isn't it? And is this kind of like an agricultural subsidy? As the world changes, we sort of want to help people out for a while, but maybe we need to recognize what's happening in the bigger picture. And then the last provocative question about what's not surprising in terms of consolidation is Medicare Advantage really the ultimate goal for Medicare? Have some people who thought about Obamacare along the way and thought about MACRA along the way and lots of other things that are driving consolidation and the push for providers to take risk and get experience with that and get rewarded for that, really pushing us toward Medicare Advantage. So I have a couple of more comments, and I'm going to shorten this because it really has been covered to a large extent. But I wanted to just point to an article that I use to think about what makes for good VBP programs. It's a RAND article by colleagues who I worked with and my team at CMS on the Hospital Value-Based Purchasing Plan report to Congress. And Cheryl Damberg was actually one of the authors. And they laid out 7 points that you should look at when you're thinking about what makes a good VBP program. Probably many of you have seen it. It was in American Journal of Managed Care in July 2010. So I'm just going to run through these quickly as maybe a way for you to think about some of your discussion questions. So first, the incentive should be a series of small incentives rather than one large incentive. So for MIPS, it's small incentives, right, in terms of payments, but it's late, it's in a subsequent year, and I don't think that's really what we had in mind. For APMs, it's a lump sum. Maybe that's headed in the right direction. So think about the size of incentives and how they're doled out over time. Second, the incentives should be based on tiered absolute thresholds, which are better than one absolute threshold. So this idea that if there's a gradient sort of pulling you along toward better performance, that's great. But wow, when you look at MIPS and its 4 components and the various thresholds and how they all fit together, you could say, yeah, that's going to give you some tiered things to shoot for and try to do better over time. But it's actually so confusing, I don't know what people are going to choose to aim for. So I don't think that's the solution there. APMs are all structured in different ways, particularly the various ACO models. So what does that mean in terms of tiered thresholds? Third, reducing time lags to increase the incentive. So we've had these government programs that have really long time lags to the payment incentive as well as to the feedback reporting. And providers, I think, have rightly claimed we don't get the data quickly enough to improve, and these incentives are really divorced from the care that's being provided. And that's not going to change, unfortunately, with MIPS. And frankly, APMs haven't gotten the data that they have needed to improve either. And then withholds are stronger. Losing something is a stronger incentive than a bonus. There can be negative reactions to the negative incentives. But when you look at MIPS and APMs, they do have these aspects of both earning a bonus as well as a potential payment penalty. And the exceptional performer bonus will be interesting to see how that plays out. Is that actually going to be part of the solution here? And then reducing the complexity increases the response. I don't need to say a lot about this because I think Alan made a great point about how the complexity really creates uncertainty about the trade-off evaluation that you have to make when you're deciding how to be successful under these programs. So this is part of the we've lost the hearts and minds that acting administrator Slavitt has used. And then last, decouple the incentive from the baseline reimbursement. Well, it's really hard for Medicare to do that when you're paying on an adjustment to baseline reimbursement, so that's a fail from the MIPS perspective. But APMs, perhaps we have a chance there. So I'm hoping in our Q&A we'll get into some of the measurement issues, but I think they've been covered by and large. The small numbers is the only other one that I haven't heard mentioned yet, but we'll see where we head on those topics. Thanks.
Well, I think when we titled this segment, Current and Future Challenges of Physician Value-Based Payment, we kind of got the title right. This was a little bit, I don't want to oversimplify the comments here, although I do like the virtue of simplicity. But I have to say, listening to the first couple of presentations, it's sort of, don't try this at home. We're Blue Cross. We didn't try it. Alan, don't, that's not where we're putting our energy. So I guess I just want to ask at the outset, maybe this is sort of the big question, which is setting aside all of the details of the 900 plus pages and setting aside all of the design issues, is the notion of an individual physician-based value anything a credible thought? And maybe, Tom, you ended with the notion of the small numbers problem, but it seems like there are many others. And I mean, I know we can critique anything, and we're all for that, but I guess I really do want to ask the question, is the enterprise of trying to do something about rewarding and promoting value at the individual physician level an enterprise worth undertaking. It didn't sound, Meredith, like you think it is, but I'm not sure. I don't want to put words in.
I don't know how to lower this or raise myself. So I would just, one thing, Alan, is that it's very apparent to me looking across at these sort of system-level payment reforms that they've lost the hearts and minds of rank-and-file physicians in them. And it is really critical for us to address this issue of what is it that we want clinicians to do now, do differently. And I believe that measurement is a part of how we change those expectations, because it's very clear right now that that most physicians are largely being driven to produce RVUs, and that's so far from what we are looking for in these reforms overall. And if we simply ignore the individual physician level and do all of this up at the system level, I think that's a problem. So I think that there's an important question there. I don't know that it's a pay-for-performance program or necessarily one single unified measurement program, but I think that's a critical question, is what do we want cardiologists to do today that was different from 20 years ago?
Dana?
So I agree so wholeheartedly with Meredith's point that we do have to figure out in these systems like ours, where the incentives are to the organization, how should and how does that translate down to the front lines? To just directly address the question, though, of is it a good idea to do measurement and incentives at the individual clinician level? My own answer is I find it hard to believe that that's the right answer for us over the long term for a couple of reasons. The first one is it sends a signal that I don't think any of us believe, which is you can go it alone and it will all work out. Right? Does anybody believe that in life, no less in clinical care? And, I used to joke when I would talk about the changes that we've seen in our own network that I shared with you this morning, that, it's hard to have a quality improvement conversation with yourself, and it usually doesn't last very long. So that's one reason that I think it's flawed to do the measurement at the individual level. But the other really important reason is the technical one that's been raised, which is sample sizes. When I arrived at Blue Cross, we did have a measurement program for individual PCPs. It, at the time, paid no attention to sample sizes, so that was the first thing I implemented. And once I implemented that, there were very, very few things we could look at the end of. We certainly couldn't look at cost. We couldn't look at episode cost, so I'm not sure how that's going to work in MIPS. But all we could really look at was a handful of preventive measures, because those apply on such a broad population. Anything to do with chronic illness or a subpopulation, there was no way to do it with sound measurement approaches at the individual level.
So I would posit that if the Medicare program hadn't been set up as a relationship with an individual provider from the beginning, we would probably be starting at a very different place right now. So we're kind of working around that. But having said that, I do think even if we'd started at a different place, we would end up saying we actually need incentives at all levels. Because that only makes sense when you're paying for something to pay for what you want to see. But the incentives are different at the levels, and to Dana's layered LAN performance measurement slide, the measures are also different. They need to be fit for purpose. So my team at Discern, along with Mark McClellan and Jerry Pinso from the AMGA, and the folks from the National Pharmaceutical Council who sponsored the project, we published a paper in the American Journal of Managed Care on a layered approach to measurement, which looks very similar to the LANS approach, looks similar to the IOM vital signs layered approach. And the idea is that you have a few outcome-oriented broader measures for external accountability. You have measures for a dashboard, probably roll-up composites that link between those external accountability measures and the measures for people on the front lines who actually do need the process-oriented measures to make sure that they're getting rewarded for what we want, which is following clinical guidelines and better engaging patients and shared decision-making and so on. So I think it's all of that.
So I'll just I'll second what everyone else said, which is you have a problem with the signal-to-noise ratio when you're looking at the individual physician because of the small numbers problem. I just want to make one other point about this, which is that the practicing physicians, these quality measures, many of them would characterize this as pay for reporting, not pay for quality. And what is driving the consolidation, in my view, is, at least in primary care, it's not the financial incentives or disincentives, which the people are blissfully unaware of and don't understand at all. It's the infrastructure that is required to comply with these requirements, and it's simply impractical at a single physician office to do that. That's why Physician Health Partners really exists, to try to support the smaller practices by sharing these resources across a wide number of people. But even then, I don't see much of a future for solo practices, or even 2 or 3. But what really surprises me when you look at the MIPS, the new rule, is you've got to have more than 25 people in your practice in order not to be a small practice. And that is an enormous change in a community like Denver, where small practices are dominant.
So I'm going to push one more and then a couple of questions from the audience, but I want to follow up on sort of where Meredith ended. That we've published a lot in Health Affairs about alternative payment models, and one of the experiences is that you do change payment at this level, but the actual payment at the provider level, physician level, or hospital level is almost always built on the Medicare chassis with some adjustment. So what I kind of heard you say, Meredith, is, maybe this isn't what we want to do, but if we don't change the starting point of all of these negotiations, when we put risk up at this level, we're not going to see the transformation. And then, Alan, you referenced, and it's come up more than once today, that a lot of what's being spent in creating these sort of networks and systems is about information technology infrastructure. Sometimes it's practice change infrastructure. But apropos of the answer to the question in the first panel, it's very rarely payment change at the individual or the provider level. So I guess what I want to push on is, if it's inevitable that we're going to do it wrong if we do it at the individual level, but it's essential that we change it at the individual level so that the system changes, how do we get ourselves out of this mess? Simple question.
I think that question is exactly how I see these new rules, is they are not necessarily a means to an end, but a means to an implosion. And without the implosion, I mean, really, when I look at these systems, and Boston is no doubt atypical, but when I look at these systems, the systems do not have the power to make the individual chiefs follow a new way of doing things. And so as long as Medicare keeps feeding those chiefs with a straight RVU-based payment, it's very hard for the system to do anything more than hire a bunch of care managers and IT professionals and try to change the system within which those humans work. And so somehow the humans have to be engaged. And so I'm not sure that there's a better way to do this, to be perfectly honest, that's feasible.
Sounds like boot camp, where you break them down to build them back up. So if we could just destroy this current program, fee-for-service, perhaps we can get to a system that better serves not only the patients, but also the physicians ultimately.
You want to?
I don't have an answer to this question, but I think we're on the right track to get the incentives right at the system level, and then to look for systems to, within them, do what I see many of our systems doing, which is to create groups, not of individuals within the system, that, call them pods, call them whatever you want to call them, that actually can be measured on a fair number of things, probably not on total cost of care, so that you can rely somewhat on incentive-based and measurement-based information. But let's remember that we should, I don't think any of us is saying that the entirety of what payment should be about is the result of these performance measures. And so we have to keep that in mind too.
I would just...
Let's get we're way past the time we have, so I'm going to take two very quick questions and quick answers, and we're going to have a break, but I know we can do this all day. Let's start with John up here. Oh, Mike got there first, and then we'll go to John.
Hi, it's Elizabeth Dry from Yale Center for Outcomes Research and Evaluation. Great discussion. Thank you so much for convening the panel. I had a question that actually spanned both panels. It's about SES adjustment. Cheryl mentioned that based on her Medicare Advantage analyses, CMS moved to adjust a few measures, 6 measures, Medicare Advantage program for SES. And one of them, I'm just going to give an example, was colorectal cancer screening. And then Dana mentioned that in her program, she saw some of the best gains among groups of providers caring for low SES patients and felt like it was important to leave the bar where it was at the beginning and that they really could step up and achieve that. And so I think that's sort of two different ways of thinking about what we want providers to do. Say, well, you know, some populations are hard, so let's adjust so we can measure fairly, versus let's hold the same bar and see if people can step up. And on a measure like colorectal cancer screening, I'm picking a less controversial one than the readmission measures my group developed, just as a better illustration case. I'd love to hear what people think is really the right way forward.
Any reactions on SES, Dana?
Yeah, so I'll jump in on that one and say, you know, when you hear folks talk about SES adjustment and the importance of it on quality measures, and let's distinguish adjusting quality or outcome measures and adjusting payment on SES. So right now, just in terms of quality and outcome measures, usually what folks will say is, you know, because there are factors that influence the outcomes that providers can't be accountable for. And I think we have to just stop and question that, because that was my intention in sharing with you some of what we saw happen with health outcomes overall. And then my tagline that those who did the best on that actually, and not just the amount of improvement they made, I'm telling you they outperformed organizations taking care of better, more advantaged populations. How did they do that? Well, they had to actually provide patient-centered care for real. They had to not, you know, do a one-size-fits-all view of healthcare and think that, you know, whatever happens out there is not my responsibility. They had to actually think about the real-life circumstances of their population and what it would take to get those patients under good control. And they did that work, and they had remarkable results. So I don't want us to quickly jump to a conclusion about what is and isn't out of providers' control. Certainly, you know, our fee-for-service system has had providers only accountable for what's in front of them, and as soon as a patient walks out or gets discharged, it's off their watch. But I think we're talking about something different now. Adjusting payment is a different matter, and I do think that the payment has to represent the complexity of the population that providers are taking care of.
Alan?
I'll just second every word of what was just said and add that the complex patients, either because of multiple chronic diseases or socioeconomic factors or what have you, those are the high-cost patients. Those are the patients that receive the worst care overall because of the complexity and all the factors that we've talked about. And those are the prime candidates to benefit from better care and more efficient care as we move the system to a value-based approach. And it is possible to intervene, but you can't do it by just doing everything the same way that you do for everybody else. So it really is a move toward being more patient-centered and considering the totality of the needs. How do you achieve the objectives that you want, not just to say, well, I wrote the prescription, and if the patient didn't take it, that's their problem.
So I'm sorry, we got to take a break because it's going to take a while to get you all out and back in. I don't want to cut David short. So please join me in thanking the panel. I hope we've sufficiently whet your appetite for the topic. Please take a break, grab a little something if you want, but we are going to try to keep it tight so we can stay on schedule. Okay, we are, just to keep us on time, I'm going to begin introducing our keynote speaker. Ask for those of you who are in the room to put your attention up here, knowing that others will be coming in as they finish with the break. When we were putting the event together, we thought about how do we make the pivot from sort of where we are now and what the current programs are to where we're headed. I'm going to ask you all to please, if you're in the room, please stop talking. It's really quite simple. If you want to talk, there's room out there. When we thought about who could help pivot the conversation from the challenge of where we are to where we might go, one name immediately came to mind, and we're so pleased that David Blumenthal, president of the Commonwealth Fund, agreed to provide the keynote today. He has a distinguished resume, formerly Samuel O. Thier Professor of Medicine at the Harvard Medical School, Chief Health Information Innovation Officer at Partners Health System in Boston. Many of you knew him when he was the National Coordinator for Health Information Technology. He has many other items on his bio and resume. He has service as staff to the U.S. Senate Subcommittee on Health, and he's the founding chairman of Academy Health, which is the national organization devoted to health services research. There's many other accomplishments, but really a thought leader. Reference was made earlier to the Vital Signs report, and he was central to that, which is, I think, the turning point in the conversation from some of the old ways of thinking about quality and value to the new. And so to help us make the transition to where we go from here, not just in incrementally improving the programs we have, but conceptualizing where we want to go, please welcome David Blumenthal.
I think it's still good morning, so good morning, everybody. I'm delighted to be here. Alan and Chip have tasked me with a not inconsiderable challenge, thinking about the future of value-based payment, and I've listened with really great interest and admiration to the comments that we've been hearing up to now, and that discussion has been at a pretty technical level, and appropriately so. I'm going to take the discussion up a bit, and I'm going to do that by talking about two things, predominantly. The first is this. This is Vital Signs, the Institute of Medicine's report on quality measurement, whose goal was to create a parsimonious group of quality measures that could serve all purposes for all times. I'm going to talk not about the measures, but about the lessons and some of the key lessons that I personally learned from trying to make this project happen. The other thing I'm going to talk about is this. Big data and what it means. So two conceptions of big data. One is the quantified self, somewhat scary version of the quantified self, but somebody who's into his or her data and is generating data all the time and it's being captured somewhere. The second image on the left here is where it's captured. The idea that there will, for all of us at some point, if we want it, be floating out there under Google's careful monitoring or Apple's careful monitoring, a personal health record or an aggregation of all our data that will be searchable individually and searchable collectively. So two versions of the big data future. Now, turning back to Vital Signs for a moment, Vital Signs was about solving this problem. Tower of Babel in quality measurement. And the way this Tower of Babel happened is through very good intentions and through the reductionist scientific method of developing lots of categories in which you find important measures, and then the development of hopefully scientifically sound elements to measure within those categories. And what you get, if you play this out, and if you let logic and reductionist logic play itself out, is you get many measures. You also get health affairs articles like this. which is about the cost imposed on physicians as a result of trying to scramble around measuring these various specific scientifically developed measures. You also get hospitals spending equivalent amounts of money. I remember there were colleagues of mine at Mass General Hospital figured out that they were paying about 1% of net patient service revenue 4 or 5 years ago measuring quality in the various forms that they were being asked to report it. In 2014, when Vital Signs began its work, there were, I think, 1,700 active CMS measures, and there were 630 approved NQF measures. So there was a lot of measurement opportunity and a lot of possibilities to choose from. So the reason I was interested in chairing the Institute of Medicine Vital Signs report is that I had this image that there was a technical solution to this problem, that we were going to come up with the measures that were going to be in the numerator, and then someone would find the cost measures that went on the bottom, and everyone would line up around these measures. Ipso facto, problem solved, Institute of Medicine to the rescue. I came to realize that, like so many apparently technical issues, this was a human issue. That value and quality are often in the eye of the beholder. Now that may sound somewhat heretical, but I hope to make the case that it's actually quite logical and simple, and I'll get back to that in a moment. But fundamentally, the insight is very simple. Value is not about something out there, separate from us. It's about what we value, what we choose to consider important. And that process of choice is something I'm going to come back to again and again because I think it's central to the dilemmas that we're facing right now. So, why do we need to make choices? There's a recognition right now that the measurement enterprise has slipped out of control, that it's counterproductive, wasteful, burdensome, and not realizing the purposes for which it was conceived and originated. Now, that means that we need to start making choices. We need to pick measures that really are meaningful. Now, picking and making choices means putting some things ahead of others, setting priorities. Now, you could say, let's start with the measures that are valid. NQF has 630 of them, or had, probably more now. So let's start with those. And the problem with that approach is this classic problem, which is it conceivably puts the care of acne ahead of the care of cancer as a national priority. And that is clearly not a very gratifying way to set about generating a measurement enterprise. One of the reasons choice is difficult is something we heard earlier today, and it has to do with the references that I heard to cardiologists and also to geriatricians. The fact is, this is a cloud, a very small version of the cloud of medical specialties that we have in the United States today and around the world. There are many, many hundreds of specialties, and they're growing in number. Each one of those specialties corresponds to a category of illness. Each category of illness relates to patients and individuals who have serious problems and whose problems deserve attention. Specialties we invited physicians to step up to the plate and help us develop quality measures about 15 or 20 years ago, very rationally thinking that they knew what quality was, so let's get them engaged. And they responded, and they stepped up to the batter's box, and the batter's box got very full, very fast. And that is part of the reason why choice is difficult, is that it involves groups of highly qualified professionals and involves the individuals, the patients that they represent and care for. parsimony, priority, choice more easily imagined than implemented. So what does choice actually involve? A minimum of two things: set of criteria for choosing among measures, and keep in mind that measures are the core of value and the determination of value. And the second is a process. In our raucous, decentralized, democratic small d healthcare system, having a process that is legitimate, that is routinized, and that is accepted and can speak for the consensus is absolutely essential to having parsimony, order, and priority in your measurement development set. You simply cannot promulgate such measures unless you also aggregate all the power to the party that is promulgating the measures. And we don't do that. That's not the way we do it. Another way of summarizing this is by saying measures and value-based payment are not ends in themselves. They are about getting someplace. And if you are not aligned around your purpose, if you don't have consensus around your purpose, you are very unlikely to get agreement on a parsimonious set of measures. This became very evident to us very early as we began this process of trying to meet our charge of developing a parsimonious set of core metrics for quality. We eventually, at the committee, settled on the triple aim as a sort of North Star for value for things that we accepted and wanted to accomplish together. And the triple aim is familiar to many of you. It's illustrated here on this slide. Upper left, management of cost. Upper right, achieving health. Bottom right, achieving quality in the delivery of services. The committee wanted to add, and we were asked to add, a fourth, which is engaged people, engaged patients and communities. As far as I know, the measurement enterprise had never been approached with this concept, this grounding concept, previously. And it resulted in some predictable, but also some surprising results. So the predictable ones were measures like life expectancy in terms of measuring health and healthy people, hospital-acquired infections in terms of measuring things like quality of care and process, immunization rates in terms of measuring healthy people and care quality. But it also led to some very non-traditional measures which were likely to cause consternation among health professionals. And those were things like high school graduation rates, or social isolation. Things for which there was a relevance to health, but were not in the traditional wheelhouse of healthcare providers. Now, Dana told a very encouraging story about ways in which maybe healthcare providers could take more control of those things, and I, as a former clinician and hospital and healthcare manager, can imagine those things, those ways, but they are not within the current imagination of our healthcare providers, except for very few exceptional or different forms of providers. So what are we doing right now with respect to the value-based payment mechanism? What is the process that we have put in place? Well, the nearest thing we have to a process is this. It's a relationship between CMS, Congress, and all those professions. And they are in a dialogue. And right now it's mostly between CMS and those professions. And add into the professions hospitals, Medicare Advantage plans, you name it, whatever the stakeholders are. There was a lot of discussion about the complexity of MACRA and MIPS, and that complexity is reflected in the nature of this process, which highly represents, as most regulatory processes do, conventional thinking and interaction with the affected constituencies, as you would expect in a democracy. But it is very hard to get choice, parsimony, and vision injected into this process. Now, I say that with enormous respect for the current leadership at CMS, which I think is really terrific. And this points out, given that this is our default process right now, the stakes of our current national elections. Because one can imagine a much more flawed process even than what we have if the election brings into power people who don't have the level of understanding and the level of commitment to this process that we currently have. So, developing criteria like the triple aim, developing a process for implementing those criteria, maybe one a little more sophisticated than this, and some of the recommendations of Vital Signs, by the way, were about that process, recognizing how difficult it is in a decentralized democracy to bring that process to fruition, but recognizing it as critical on the way to developing a value-based payment program that works without being excessively burdensome, wasteful, and ultimately illegitimate. So the second area that I was asked to talk about is data, big data. This is big data, it's big, and it's dynamic, and it's got things coming out of it and going into it. Now, some people are just delighted with the idea of big data, and I confess the wonky part of me is really excited that we're going to have all this data around, and I suspect there are some folks in this room who share that generally positive attitude toward the idea that data is going to be out there in the cloud, ready to be massaged and turned into something exciting. Other people have a slightly different view of big data. They worry about privacy, and I'll get to that in a moment. They worry about the manipulation of the data. They worry about it being used for private purposes rather than for public purposes. Just think about who you will trust, who you would trust to keep your data, and you begin immediately to think about why there might be a cloud on the horizon. But let's put that aside right now and think about the opportunities. I do also want to say that for all the criticisms that are appropriately leveled at electronic health records, this dynamic is one reason why we have big data, is because through the hard work and sweat and sometimes pain of physicians and other health professionals, physiologic and physical characteristics of people are being captured in electronic form. And I'd be happy to comment on why it is almost essential that there be people involved in that process, no matter how much we might want to automate it. But that's another subject. There's another reason why big data is happening, and that's this. We have a big burgeoning new industry that is just salivating over the idea of getting access to this data and using it for the things that we as Americans embrace and celebrate, and that is making markets, making new businesses, and making money. There is no lack of interest in the consequences of the electronic health record phenomenon among Silicon Valley entrepreneurs and Silicon Alley entrepreneurs. What are the challenges to using big data for value-based payment? Well, there are many, and they're substantial, and they need work. The first is health information exchange. Anyone who's been in healthcare and has even sort of listened at a distance to discussions about electronics knows that we're unhappy with the level of exchange of health information between those electronic health records that everyone has been laboriously implementing, and between institutions and between segments of the healthcare economy. So that's all a important consideration. I mentioned privacy, cybersecurity. When the Office of Personnel Management and the Pentagon seem so vulnerable to penetration by hostile forces, it does give you pause about the security of any repository of healthcare data that attains a certain magnitude. And there is growing evidence that hacked data, healthcare data, has substantial value to criminals and other bad actors. And then, last but by no means least, there's analytics. And here I want to emphasize that data has no value. It's hard to keep that in mind, but data is often more confusing than helpful. What has value is information, which is the data processed for use and presented in a way that can be used. And we have been very slow even to use the data that we currently have, not to mention the data that's being accumulated, but data we currently have to support better decision making in healthcare. What can data properly used, if we solve all these problems, what can it do for us, big data? Well, it can create, first and foremost, value through new knowledge. The value we seek is at the frontier of our capabilities of producing better care for people. And the more we know about the underlying physiology, the underlying disease mechanisms, the underlying patterns of disease, the epidemiology of disease, the better we can care for it, and the more value care has. That is a wonderful, positive, virtuous cycle in healthcare. And the other thing we can do is create new measures, and that is sort of a logical result of knowing more. And the third, and perhaps most speculative, is that we may, through the creative use of the computing capacity that enables big data, reduce measurement burden. I'm going to say a little bit about the first of these, because it's the most exciting, and just a little bit about the last. So, examples of big data producing new knowledge with big potential benefits. Sorry. So this, Francis Collins from the NIH blogged about this article, which appeared in Science Translational Medicine about 6 months or a year ago. It was work done at Mount Sinai Medical School, and it used big data from an aggregation of electronic health record data to identify that diabetes patients, type 2 diabetes patients, adult onset diabetes, seem to cluster into 3 groups. So not everyone with type 2 diabetes may be the same. It may be that by looking at their non-diabetes related characteristics, you can identify patterns that suggest that their mechanism of disease may be different. Diabetes may not be diabetes, may not be diabetes, and the result could be different kinds of care, personalized, targeted, better. So that's one use of big data. I'm sure most of you remember the Vioxx kerfuffle about 8 or 9 years ago, 10 years ago. So it turns out that at Partners Health System, where I worked before I came to the Commonwealth Fund, the data that Partners had aggregated from its electronic health records, since it's had electronic health records for several decades, in part thanks to David Bates, who's sitting here in the front row. If they had gone through their data and looked at their patients who were taking Vioxx, they would have detected the relationship between Vioxx and cardiac disease way, way, way before it hit the New England Journal, because it was there in the data. The association was detectable through the use of aggregated electronic health record data, just sort of taking out the Vioxx patients and looking at their rates of cardiac illness. Another area where big data has had an impact, though this a more cautionary one, is in understanding the relationship between estrogen and postmenopausal well-being among women. So big data initially, mostly through epidemiologic studies, suggested that taking estrogen was a good thing for postmenopausal women. That turned out not to be so true. It took a traditional clinical trial to demonstrate that, in fact, there were many other consequences, negative consequences of estrogen, especially unopposed estrogen, that made it a very not so good idea to continue to administer estrogen to women. So big data offers opportunities for improvement in our knowledge, but also opportunities to mislead us, because there is still and always will be uncertainty around epidemiologic aggregated data that only clinical trials can disaggregate. Now, I mentioned one other thing, and that is the possibility that the computing power that we are developing could reduce the burden associated with monitoring. Now, I don't know quite how this will happen. I put it up here as a kind of galactic vision. But you can see here sources of data, sources of support for data, and conditions for the data's use. And the concept here is that if we have this information and we figured out how to use it, we can begin to look at parameters related to practice without involving the individuals who have to do the reporting, reducing the burden on clinicians to report, reducing the burden on organizations to report, and essentially doing it through machine operations. I think that's possible, but it involves a lot of the work of decision support and of analytics, scientific experimentation. It's a really hard go. So I hold that out as a possibility, but by no means a certainty. So just to come back to the key points that seem to me to emerge from these two perspectives, the perspectives of the vital sign report and the perspective of big data. Value is in the eye of the beholder. In a democratic country, we have to come to agreement on what we think is valuable. We have to have common purposes to confine the measurement and value-based purchasing enterprise to a manageable, administrable enterprise. New technologies don't solve problems, and sometimes they create problems, but they create opportunities for humans to solve problems. So it all comes back to us. Just by way of a side point, the more I have been involved in technology policy, the more I have come to see that the problem is usually humanware, not software. That it is what we do with these technologies that really conditions their return, not the technologies themselves. And then finally, big data is a huge resource if we can decide what we want to do with it. And whatever we do with it is going to be a hard, long go. But I think a statement of faith and value, more than certainty, will be well worth it in the end. Thanks very much for your attention.
So we're running a tiny bit behind, but I want to ask one question just to launch really the next panel, which is add the experience of or the part of the conversation from this morning that you were able to catch about the use of these new resources and a more person-centered conception of value to the notion of rewarding and improving, which at the Commonwealth Fund is a huge goal that you have. So help us with start the next step, which our next panel is going to take in terms of thinking about how these three key points lead us to the quality improvement enterprise.
So that's what you really wanted me to talk about? That's a really hard go, and I'm not sure I have captured I guess I come back to the point I was making, which is that intentionality, which is so hard to capture, is so critical here. And the process I showed, which was CMS, the Congress, and the professions working together, is where we tend to go in trying to find intentionality. And Congress doesn't want to deal with it, and the professions collectively can't deal with it because they can't agree. So we leave it up to those hard-pressed CMS administrators and managers, and then we kick them really, really hard. I think the process that we will need to create a set of metrics that will lead to a value-based capability is going to be a consensus-based development process that involves multiple sectors, and we are going to have to create a legitimate way of setting priorities that will prove itself over time and gain the confidence of the key stakeholders. And one thing I do want to emphasize is that the default process we have in place right now does not represent the entirety of the private sector. It doesn't represent payers, for example, and it represents the public through the Congress, but that is a very indirect form of representation. So I don't think I answered your question, but I answered a question that I could.
Well, I think you answered the question in terms of helping set the stage both with the presentation and the answer to how we map the technical as well as what you really sociological and organizational political challenges of this enterprise having a goal that ties back to what people want. So thank you, David, very much for these thoughts. Please join me in thanking you. So we are going to move seamlessly to our last panel so we have enough time to engage them. So I'd ask them to come up, and basically what we're going to do is use David's remarks as the launching point for a discussion that goes to some combination of the technical as well as I think the organizational issues that he introduced. So for our final panel, we have David Bates, Senior Vice President, Chief Innovation Officer for Brigham and Women's Hospital, Professor of Medicine at Harvard Medical School, and Professor of Health Policy and Management at the Harvard School of Public Health. We have Frank Opelka, Chief Executive of the LSU Healthcare Network. We have Melinda Bunton, Chair of the Department of Health Policy at Vanderbilt University School of Medicine, former Deputy Assistant Director for Health at the Congressional Budget Office, and Eyal Zimmerman, Internal Medicine Physician, Senior Executive Team at Sheba Medical Center, and Deputy Director and Chief Quality Officer, as well as formerly the lead researcher at Partners Healthcare Clinical Affairs Department. So a lot of New England representation in this panel, but I think it's a great follow-on. Let me turn it directly over to David.
Thanks so much, Alan. My remarks have been sort of presaged by John Perlin and David Blumenthal. I'm going to be talking about using big data to improve patient care, and the term we coined, the era of precision delivery. What has changed in the last few years? Well, a number of people have made the point that we do now have lots and lots of electronic clinical data that are available. That's true both inside the hospital and outside it. Another thing that's happened has been that natural language processing is now a routine sort of thing. So we can get data out of narrative, which we didn't used to be able to get. And then there are many other sources that we can go to, including genetic and genomic data, but also social data and mobile data. This is a paper that we just published in which we coined the term the dawn of precision delivery. It was published in JAMA a couple of months ago and worth taking a look at. But I'm going to frame my remarks this morning around big data in clinical care, and these are some practical examples from the healthcare big data issue which relate to use cases that organizations can use now to improve the efficiency of the care that they're delivering. And those are high-cost patients, readmissions, triage, decompensation, adverse events, and treatment optimization. So high-cost patients are important because high-cost patients, at least in Medicare, account for about half of the spending. And if you are managing a population, I'd argue that the first step that you should take is to identify this group. You have to have some information about what's going on for them with respect to mental health, their socioeconomic status, their marital status, their living status. Fully half of them have some sort of substantial mental health issue, and if you don't address that, it will be hard to get to where you want to go. We argued in this paper that with big data, what you could do would be to get to specific actionable needs and gaps. So what's relevant for an individual patient typically varies quite a bit, and we ought to be able to use these sources of data to figure out what that is. I wanted to tell you what our organization is actually doing right now. I'm from Brigham and Women's Hospital. We use a tool called the LACE to risk stratify patients. We take claims data from the last 12 months. There are clinical conditions from a list of about 30 that are categorized as high, moderate, or low acuity. We take then combinations of conditions from each category to figure out how clinically complex the patient is, and then hospitalizations, ER visits, and other types of utilization trigger inclusion. Our population includes about 3,000 patients. Most of them are women. They're elderly with an average age of 71. 32% have a formal mental health diagnosis, but probably many more have one. They take an average of 17 medications, so they're a complex group. Their per member per month costs are about $2,000. That's 2 to 4 times the average costs. And their hospital admissions account for over half the costs. So that goes back to what David Baker said earlier in terms of perhaps focusing on admissions instead of other things. And in fact, we've been able to show that by using this approach and having a care manager work with patients, we've been able to, over time, decrease their inpatient discharge rate, which is exactly what you'd want to see. Readmissions has also been a major target of CMS, and I would endorse the things that were said earlier about moving away from readmissions. But you should today use an algorithm to predict how frequent they're going to be. And then the key differentiators, I think, are likely to be tailoring interventions, again, to an individual patient, ensuring that patients actually get the intended intervention. We have a set of 4 to 5 things that we want every patient to get, but what we find is that many of them don't actually get what we intended despite our best intentions. You probably want to monitor specific patients after discharge. That's been demonstrated to work for conditions like heart failure. Triage is another very big opportunity. So data can be used to estimate the risk of complications when patients are at a critical juncture. They're being admitted, they're being evaluated, they're being transferred. If this is going to work, the experience has shown that you have to have a detailed guideline that clarifies how the algorithm should inform care. And a couple of examples from Kaiser that have been very effective are evaluating newborns for early onset sepsis and using emergency department composite scores to predict decompensation. Decompensation is also a very big target, and tools are now available to monitor patients, and that's, I think, especially important outside of intensive care units where we've monitored patients fairly aggressively for a long time. You can track a lot of parameters with wearables. You can use even devices that don't contact the patient. For example, ones that sit between the mattress and the bed and can measure the patient's pulse and respiratory rate. In one trial that we did, a device that did measure pulse, respiratory rate, and how much the patient was moving, that decreased the number of subsequent ICU days by 47%. This is the kind of thing that can improve value. In intensive care units, I think it'll be especially valuable to take all the data that we have and put it all together and look for trends. And that, again, is not done routinely today. So to wrap up, clinical data are now nearly ubiquitous in the U.S. We have them in over 80% of hospitals and also in the outpatient setting. And yet, I would underscore that most organizations haven't yet figured out how best to leverage these data, and they don't really have robust plans for doing that. Every organization will need to invest. If there are incentives for, that pay people for value, they'll have resources to do that. As David Blumenthal just suggested, I think big data approaches are going to result in many insights, both in clinical care and research. I underscored a few of the ones that I think will deliver value earliest. And if you want to look from the bigger picture at what is going to help the most at the margin in terms of doing better with these predictions, I think it will be novel sources like social data and mobile data, which will enable us to identify many things that we can't today. Thank you.
Is it still morning? It is. Good morning. So I'm Frank Opelka with the American College of Surgeons, and some of our efforts I wanted to talk to you about as we're approaching, I don't yet think we can call it big data in our environment, but how we're looking at measurement going forward in this new era that we're calling the quality payment program that's out there. And as I think about this, where we are in measurement, to me, has been top-down. Where we need to be is to add into that top-down the bottom-up. And there are requirements in the measure architecture to get us there. And when I look at it from the provider standpoint, they're traveling down one of two pathways, whether it's MIPS or APMs. From a data standpoint, they don't want to bother. They don't care whether it's a MIP or an APM. It's a patient. So this is all about the patient care, not a payment system. And then we'll tack on a payment system to it. But from the clinical point, from the nurses, the pharmacists, from those that are at the bedside trying to care for a patient, that's how they're thinking about this. And when they see this, what they want that data to do, and they know that that data can do for them, is give them an active dashboard that allows them to drive optimal care. And that's how they're living in all the rest of their industries. Banking, grocery, Amazon, you name it. They can get information that's useful to them. We haven't built that yet out of the architecture that's in the data world. So if there's one slide I want you to take home, this is a scaled down version of what the data architecture ought to look like. We've spent an enormous amount of time calling meaningful use to EHRs. EHRs are the most wonderful enabler. That Dr. Blumenthal highlighted it. It's done marvelous things to bring the data architecture forward, but it's not the endpoint. Stop looking at EHRs and look at the cloud. What attaches to the cloud? It ought to be public servers. It ought to be payer servers. It ought to be clinical EHR data, lab data, EHR data, connections to other care points, whether it's home health, skilled nursing, you name it. And to the right, you see a list of dashboards. Those define meaningful use. There's leading indicators and there's lagging indicators, and then there's research aspects of this data. Now we're starting to frame data in an architecture that I clinically can say, I know what I got to do. What do I mean by a leading indicator? If I touch the local pollen count and I figure out the pollen count is going up, that's not in my EHR. But I know when it reaches a certain threshold, I need to go to the EHR and activate all my asthmatics who've got any kind of inhaler and wonder through the pharmacy data set whether or not that inhaler prescription is renewed, current, and active. And those that aren't need to get a smartphone message to get it in line because the pollen are coming. They're going to miss school, they're going to miss work, they're going to be in the ED, they're going to be in the ICU. That's a leading indicator. That's how you leverage data for better health care. And that's how we ought to be looking at this. These dashboards can be very complex. This is a dashboard mock-up we're building for every surgeon at every point in the country. It'll have cost data when they need it. It'll have individual patient data when they need it. So as a surgeon, I'm seeing a cancer patient. I can go through Epic Click Trauma and try and figure out what date were they diagnosed, what was their stage of diagnosis, what operation did they have, what chemo did they have, what radiation did they have. Or I can build it into a dashboard that when that patient comes in, that's presented to me. And now, instead of looking at Epic and clicking through, I can actually stop for a minute and take a look at a patient. Oh my gosh, what a shocking adventure. It all has to fit in this architecture because it has to lie on top of or touch to a payment system, and it can be built to do that. When we look at it from the College of Surgeons standpoint, we're registry-based. We've got huge 5 registries with terabytes of information, the National Cancer Database, the Trauma Database, the National Surgery Quality Improvement Database. I have over 800 data elements with about 5 to 6 metadata elements per data element moving into this framework today. We've automated a third of that. Within the next 2 years, we will have all of it automated. There will be no burden to this aggregation. These are data flows that are moving then to the point of delivering health care. There are rigid structural data requirements to do that because we're going to base care on this, so to have reliability and validity that nurses, physicians, clinicians can trust, the patients can trust, you need to have rigor of unparalleled activity. We've then broken down the ability to look at all the phases of surgical care. Instead of measurement of saying, I just want to look at surgical site infection, or I just want to look at readmissions for this or that. I want to look at all aspects across the continuum of care of all the providers, not just me, the surgeon. How are we as a team delivering? So we look at that, and then we start to build our framework. Here's one of our registry outputs that in the green shows outstanding performing hospitals, and the red shows underperforming hospitals. These are benchmark activities that should be coming back at least quarterly to the bedside, to the clinical team, to the lead, to say, here's how you stand. I tell you that when you give people data like this, they love it and they hate it. It's never right, it's never theirs, it's never this, it's never that, but they only want more. And once you create that addiction, now they're going to react to it. It's genetically bound to us from the moment we're born. We start walking, we want to keep up with our mother, and the next thing you know, we're running and we want mother to keep up with us. We compete. So this is a key part. Here shows these deliverables. We've actually looked at this. We've decreased complications. We've decreased mortality. We've actually got it down to improving 1 complication per day per hospital that looks at data in this architecture. When we talk about the new system that's coming, those old data systems I just showed you are 30-day outcomes, risk-adjusted outcomes. We're now looking at 90 days if we go into a procedural or a treatment episode, and we've built out multiple procedures to begin moving this forward. We have condition episodes that aren't just an operation, but a patient diagnosed with cancer, and their time window is at least 90 days. It may be a year long. And many different providers will touch that patient. And we've built out many of those episodes, all of these to be converted into an APM architecture. Here are just some of the examples of what measures look like when you ask teams of surgeons, what are the things you want to improve? Never let data stand in the way of what you want to measure. That's our mantra. We'll figure out how to get the data. Tell me what matters to you and your patient. So are the goals of the patient of care cataloged? Have we got major comorbidity conditions identified and coordinated across the entire care system before surgery? Have we got the modifiable risk factors in line? Have we identified them and begun to attack them? This is how you get a patient ready for surgery. That's that pre-op activity that goes on. The pre-op medication, the critical med list that has to happen. Have you put the patient into the risk calculator and given that patient their specific risk for surgery? I'll show you that in a minute. And this kind of wraps up on our starter list of 10. CMS wanted some outcome measures, so we threw those into the mix too. This is the risk calculator. It's in the public domain. This sits out on the web. This can be woven into the big data architecture, but it goes up to the cloud. It says, I am who I am. Here are the conditions I have. Here's my current medical status. Here's the operation that's going to be performed on me. What are my expected outcomes? And this patient that I've lined up here, everything came out into the red. This is a high-risk patient. So it's the standard green light, yellow light, red light warning system. This ought to be wrapped into every bit of informed consent for every patient. Finally, we connect to these now using smartphones. We're now working on the patient-reported outcome piece of this, and how do we actually connect to the patients in using their smartphone technology. So we actually have an example of this. I'm from New Orleans. We have issues with Mardi Gras. Take the diabetics around Mardi Gras. So the Thursday before Mardi Gras, we text through the cloud all the diabetics and say, why don't you send me your blood glucose for the next 5 days until we get through that Tuesday. And then we put in alerts back to the PCPs when somebody's off the charts. We try and get in front of where that patient's heading. This is how big data can be leveraged. When you put it together, you form collaboratives that lead to people working together to drive improvement. We've got them in Tennessee, we've got them in Florida, we have national ones. They're in Michigan. These are very active engagements when people look at data and try and solve problems together. One quick look, because I gave you the surgical look. This is from LSU. We put together the chronic care medical home activity, and so we can look across multiple diseases. All of this goes into a cloud architecture. It measures 2,000 measures that are on about 200 apps in the cloud that click out, what we call click. It comes up as a dashboard right next to Epic or Cerner, Meditech or Allscripts. Believe it or not, I've got 10 hospitals and I don't have one EHR, I got multiple. But they get this. This is one of those dashboards. It tells them about the patient. Go get this out of Epic or Cerner, God bless you. You're going to be clicking 300 or 400 times. This comes up instantaneous, and everything in yellow is out of compliance with the medical home. So the patient's in for a runny nose, but you have an instant checkup on them. This is what big data movement starts to do when you leverage it this way. We can measure how the medical home standards are doing in blood pressure monitoring. We can move those across multiple cities with blood pressure monitoring. This is the same thing. We can add in diabetes and see how the diabetic blood pressure monitoring is occurring. All of this occurs in what we call the cloud. Now, people think that's a server. It's not. In the middle of the screen is the cloud architecture. If the Brigham was on the same cloud that I was on, and Intermountain was on the same cloud that I was on, and they were on the same cloud at Mayo, we could exchange apps. And we could accelerate this movement at a rapid pace. So Intermountain, Mayo, LSU, others, over 200 of us have formed a collaborative to define that common cloud architecture. We need to then take all those specialties that Dr. Blumenthal pointed to and get them writing apps on that cloud architecture. And we will accelerate these dashboards at an alarming rate. So this is that one slide I wanted to leave you with. Think about this not as the EHR for meaningful use in the big data architecture. Think about this as the cloud, and think about what the patient dashboard looks like, what the payer dashboard looks like. I gave you the provider dashboard. Thank you very much.
Great. All right. Good morning, and I'm delighted to be here. And at this point in the proceedings, you'll appreciate that Tim Valak and Frank Opelka took both of my introductory quips, so I'll be even more brief than I was planning to be. But indeed, I always thought I would be kind of brief because I thought I'm the kind of person who likes to let my data speak for itself. And I'd rather do that than make the kind of general remarks that come at the end of an event like this. However, when I thought about it, and I thought about what had happened in the 7 years since I went to work with David Blumenthal when he was National Coordinator for Health IT, I realized that I had a bit more perspective than I'd realized. And I have seen so many major changes in those 7 years that I think despite all the obstacles that we've been hearing about all morning, it's actually probably mentally healthy for us to go through them. And so I'll give you 7 big things that I've noticed, one for each of those 7 years since the passage of high-tech. And then I'll take you through some thoughts about where we still need to go. So here, 7 years ago, we had very low rates of EHR adoption, much less anything that we would call meaningful use, or really systems that did much more than billing. So David showed us that chart for physicians and hospitals, and those rates have skyrocketed. 7 years ago, we just recently documented the high rates of readmissions in the Jenks et al. Article. And now we're talking about phasing out our readmissions penalty program. 7 years ago, patient engagement was a radical idea. And now it's institutionalized with personnel and offices and staff in lots of our major institutions. 7 years ago, we did not have consensus on core measures, or really even what we were trying to measure. And now we have things like the IOM report and other documents that are helping to guide us in where we're going. 7 years ago, we didn't have any stepping stones, really, between fee-for-service and full risk. And these are really important to get us where we're trying to go. Stepping stones like bundled payments, like ACOs, where there's shared risk or risk for part of a patient's care. 7 years ago, we didn't know yet that data analyst or data geek was the coolest job in the 21st century. And in short, 7 years ago, we could only hope that we would be talking about the unintended consequences that we've heard about today. And I think that's real progress. So I was also, this rate of change was driven home to me further when I realized that the 7th Health Data Palooza was this week. Do you remember, do any of you in the room remember when this was kicked off as a movement 7 years ago? So we had our 7th annual one. And there were a number of memorable statements made by Vice President Biden, Secretary Burwell, and they've been retweeted in the past few days. But I think this one from Andy Slavitt is really the most relevant to what we're talking about today. He's defined a physician data paradox. He said physicians are overloaded on data entry and yet rampantly underinformed. Rampantly underinformed. And I would urge you all to read his full remarks. They're available on the CMS website, and they're really interesting. They make for a compelling read and a nice personal narrative of what he has done while acting administrator and what he hopes to do in his remaining 8 months there. But I would note that while this is a serious paradox, it is also a seriously high-class problem to have instead of having no data at all to work with. Also interesting in the past couple of weeks, and worth a listen, is the new SoundCloud podcast that Dan Diamond is doing. So I'm enough of an inside DC person that I'm listening from Tennessee. And one of his first started with Farzad Mustashari, who was mentioned recently, was David Blumenthal's successor as national coordinator. And it starts like this. He says, "I hate compliance. It is such a low bar. It is such a pity to waste one's time checking boxes." And let me tell you, when I heard that at my kitchen table, I thought, oh, that's right. That's really right. But I think we all agree, we all know it's time to move on from that. We're talking about things that are different from meaningful use. And we have done what we've done with all the programs that we've put in place, all the regulations we've seen in the past 7 years, the incentives, the committees that people in this room have served on. We've put in place the building blocks to move beyond that. So one of the things that we've done, for example, is put in place those health IT adoption building blocks and the demonstrations, as I mentioned, like primary care medical homes and ACOs. And when you start to put these things together, you start to have greater leverage and movement on the things that we care about. So here's my data. I think we put into place mutually reinforcing policies. These charts are from an article that came out last month and was authored by my former colleagues at the Office of the National Coordinator, and it came out in the American Journal of Managed Care. And what it shows is that practices that implement both an EMR and are exposed to a payment demonstration like primary care medical homes or an ACO are much more likely to perform better care processes, to do them at greater rates than those practices that don't do them, and that this appears to be a cumulative effect. So you can see in the top gray bars, the practices that don't have an AHR and don't participate in a payment demonstration. In the lighter blue bars, the practices that have an EHR but don't participate in a payment demo. And then the bottom bar, which is the longest in every case, is the practices that are using an EHR and participating in a payment demo. And I'm not trying to assert causality here. I'm just trying to show how these things build upon each other, and also show that we're getting up to pretty high rates in some of these domains. I think the most striking one, and one of the ones we've been talking about a lot here today, is the top set of bars, which is quality measurement. So you can see without an EHR and without participation in a payment demo, we're looking at only 22% of practices doing quality measurement. Once you add those two things together, you get over 70%. It seems like it has less effect on things like care coordination, for which having an EHR, which I'll talk about in a moment, is insufficient. But I think that this is really promising and shows us the value of these building blocks we've been putting in place. Similarly, this chart from the same article shows us the tiny fraction of practices that are able to do things like create reports or submit clinical care measures, or do basically any quality measurement at all without computerized processes. So, where does this leave us? It still leaves us, perhaps, with many unintended consequences. And credit for this picture goes to Michael Millinson. He was clever enough to discover that there was an episode of Doctor Who that was written but never filmed in the 1970s, and it was called The Macra Terror. And in this, this written but not filmed episode, there's a colony of humans who toil in mines trying to get a substance that it turns out they're told will benefit them, but it actually benefits their insect overlords. I'm not going to play out the metaphor for you any further. So what are the remaining challenges? I'm going to do 7 again just for balance. But I think we have data entry overload, as Andy Slavitt said. And we need to find a better way to passively mine data, as David Blumenthal alluded to. We need to fix the lack of data exchange between providers. We need to provide for a process to continually evolve quality measurement so we don't top out. We need to create trust in our system, including trust that data will be secure. We need to account for socioeconomic status when adjusting quality measurements and payments to maintain credibility. We need to break free of fee-for-service, both as a default system and as a basis of targets for our supposedly new and novel systems. And then finally, we really need to do a better job of measuring and incentivizing patient-centered care. And I put this picture up as my final slide because when I'm in a hopeful mood, I think that this is the answer to many of our problems. And I hope it doesn't just become another checking boxes exercise, but really starts to drive everything we're doing in the healthcare system. Thank you.
So I think we can officially say good afternoon, right? So first of all, I want to thank the organizers for inviting me to speak. I think this is a very important event. Actually, today is Israel's Independence Day, and I missed that to come here. Of course, my family is not that happy, but again, I think it's a sacrifice worth taking. So what I want to share with you in the next few minutes is sort of my experience with what you see here, paying for person-centered value, not just patient-centered value. And it comes from both of my past experiences, both in Boston at Partners Healthcare, where I was fortunate enough to be a part of the strategic care redesign program that Partners has gone through, starting from about 2010, and then in the last 3 years as Chief Quality Officer at Sheba Medical Center and sitting on the committee at the Ministry of Health in Israel on quality control and quality measures. Okay, so first of all, it was David Blumenthal mentioned this before, the triple aim for driving value, and we're talking about better health for populations, better health for patients, and cost containment. We seem to be doing some work on health for patients, maybe a little more work on health for populations lately, and very little work on cost containment. But what I want to focus on, and as I got this opportunity to speak, I was sort of thinking between myself whether I would go for the better health for patients or the cost containment, because I think both are very, very critical, and there's been a lot going on both, and the patient-centered care both, and the cost containment piece, especially on assessing cost. How do we know how much a patient costs us to the system in a very accurate way? There are things that are moving forward in this direction, but that's not the topic I chose to talk about today. But of course, as a side mark, it's a very interesting and important topic to also to discuss. And then David Blumenthal also had something like this. We didn't coordinate this in advance, I could assure you. So what are we measuring today? We're measuring what's under the lamppost. We're measuring what's easy for us to measure. Is it what we need to measure? Is it what's important to measure? I'm not sure. Some of these are important, some of these are not so important. We have these evidence, conflicting evidence that sometimes that improving process measures doesn't always lead to improved outcomes. There's been many examples of that. I won't cite them. But we know that we have a problem with measuring the right stuff, what we need to measure. And how do we define value? We call it value-based purchasing. Is it actually value? Or is it quality, or is it just one part of quality, which is mostly process and some of the outcomes, and are these outcomes actually the outcomes that matter to patients? So all these are questions that we asked ourselves at Partners Healthcare in 2010 when we wanted to go through this care redesign. And I don't know if Dana Safran is still around, but she was there from the payer's perspective in Boston during those years, and they were part of why Partners felt compelled to go through a care redesign. As we all know, it's not something somebody really jumps into doing. It changes everything that, every concept we're thinking about. So Michael Porter, of course, which we all know is all about value for patients, and he's saying the central goal in healthcare must be value for patients. But notice this, not access, volume, convenience, or even cost containment. Well, Porter says if you focus on value for patients, everything else will just fall in. And I tend to agree with him. I had the privilege of working with Mike Porter during those years at Partners. And then he also says healthcare systems need to be redesigned so that they dramatically improve patient value. And I think the most important word here is dramatically. If we redesign our systems to drive value for patients, we're not going just to improve value by 10 or 20%. We could improve value by hundreds of percents. And I'm a firm believer of that, and I think that some places have actually shown that to happen. And then we said, okay, so we're measuring value. So what's value? And value obviously is outcomes per cost. But when we're measuring value for patients, what are the outcomes we need to look at? Are these mortality outcomes, readmissions, complications? Is that what interests the patient? Well, maybe if you're going to a very, very sophisticated operation and you just want to come alive out of the operating room, that might be the right outcome. But in most cases, that's not the right outcome. If we want to have our hip replaced or a knee replaced, we don't care about our chance of dying because it's very small. We're not going to the operation so that we don't die. I guess you all agree with me. We're going into that operation because we want to get value. We want to be more functional. We want to be able to play with our grandkids. We want to be able to play golf now that we've retired. That's the value they are interested in most of what we do in healthcare, any way you shape it. And these are the outcomes that we need to put into that value equation. Then it would be value for patients. And that's what needs to drive the healthcare sector. So what would be outcomes that matter to patients? Again, if you're going through hip replacement, it would be functional status, obviously. If you're going through cardiac surgery, it's also functional status, but then you're starting to think about survival also because it's your heart. And we know that could have other consequences. If you're a cancer patient, you want to think about survival because that's foremost on your mind. And then, of course, quality of life comes in second. And if you're diabetes or chronic condition, you're interested in quality of life. Maybe later on also about survival, but first of all, when I find out I have diabetes, how is that going to impact my day-to-day life? How can I make that have a lesser of an impact on my day-to-day life? So what are patient-reported outcomes? Well, first of all, at some point at Partners in 2010, I was charged with finding out what were outcomes that matter to patients. That was my first task as part of the care redesign process, and soon enough I found out that it was actually patient-reported outcomes. We did a lot of research, we did a qualitative analysis, we interviewed many institutions that are doing this, and we found out that this is what we need to focus on. And so that's information about the status of a patient's health condition that comes directly from the patient without interpretation of the patient's response. And these could include symptoms, and I would argue symptoms are something we collect every day. When we ask the patient, do you have chest pain? That's a symptom. It's a critical, valid question. We need to know, does the patient suffer from chest pain, so we could relieve him from that chest pain. Functional status, notice this, not just physical, but also mental. And then health-related quality of life. These are all types of patient-reported outcomes. Now, why patient-reported outcomes? First of all, let's talk about intended consequences. We seem to talk too much about unintended consequences, what we don't want to happen. What about what we do want to happen? We're building a system today that focuses on not achieving the unintended consequences without dealing with the intended consequences. If a patient goes through, again, a hip replacement surgery and it doesn't work, and he comes back to his orthopedic surgeon, what does the orthopedic surgeon say? He says, well, I told you it doesn't work most of the time, or some of the time, right? So you can't blame me, right? And that's it. That's the only accountability we have currently. We know that not every patient that goes through hip replacement would have an improved functional status. And if it doesn't work, it doesn't work. We've done our best. That's it. End of story. The patient needs to take care of himself now with his new condition. So I would say we need to focus on the intended consequences and not just the unintended. As I've said, it's value seen by the patient, which of course needs to happen. Across the continuity of care, patient-reported outcomes are classic continuity of care measures because they don't just look at what happened inside the operating room, but what happened in the physiotherapy right after. So ACOs are perfectly positioned to be working with patient-reported outcome measures. They support accountability, just like I said. If the patient didn't get what he needed, somebody needs to be accountable. And then there are additional benefits like patient activation, comparative effectiveness, which people talked about this before, and also transparency by itself will drive value even if we don't have a pay-for-performance program, just transparency itself. Now, there's been a lot of experience. I won't go through this in the US, but it's very local. Some of you are very familiar. The Dartmouth Spine Center, Sloan Kettering are doing excellent work in the urology clinic. Partners, the program I launched and is now moving forward, Cleveland Clinic. And recently registries like the Society for Thoracic Surgeons that included that, and National Neurosurgery Quality and Outcomes Database that is doing fantastic work, but it's very, very local. There is more international experience that is done on the national level, like in the UK. First country in the world to implement a national patient-reported outcomes program, focusing on 4 surgical conditions: total hip replacement, knee replacement, varicose veins, and hernia repair. Don't ask me why. These are the 4 they've chosen. And then they have results, which we won't go through, but they actually have results. What happens to their patients countrywide? National program, all of their patients. And of course, they could compare hospitals. In Israel, we have a national demonstration program that I'm leading now that has a coronary artery disease, prostate cancer, and cataract surgery. These are the first 3 we've decided to tackle, and a couple of more are lined up next. And just as an example, the coronary artery disease patient-reported outcomes is not just the cardiac surgery, but it's also patients coming in with acute coronary syndrome, myocardial infarction. So whatever condition you're coming in with to the system, we'll be tracking you. You'll be completing your information through the tablet at first when we sign you up, and then we'll follow you up at 30 days, 3 months, and 6 months through the internet or through the phone if you're not tech savvy enough to use the internet. Every patient gets this report. Of course, it's in Hebrew, but you could imagine what it says. This is for the coronary artery disease patients, so they know exactly how they're doing on symptoms, on quality of life, on functional status, and on mental status. So what needs to happen for PROMS-based, value-based purchasing to be a reality? First of all, we need to see widespread adoption. We need to decide whether it's technology-driven, paper-based, or telephone-based. Different countries have taken different approaches. Who pays for the infrastructure? Good question. How do we get patients to play along? If they don't play along, we have a problem. It needs to be used, and we have a lot of experience with that, and we understand that for patients to play along, the clinicians have to use the data. So if the clinicians actually use the data to treat the patients will keep on providing that data. So we need to actually first change our physicians, which, as you know, is not less of a daunting task. Case mix adjustment needs to be worked out, of course. I won't go into that, but there's a lot of experience in that direction also. So what do I think should be next steps? I think CMS needs to take the lead, just like with many other programs. We need to establish a framework and a roadmap. We need to look at other countries and see what is working and what is not. We need to decide on payments for infrastructure investments, just like meaningful use. We need to pay for reporting at first, based on response rate. If some hospitals or ACOs are providing 60% or 70% response rate, they need to get paid more than if you're just providing 40% response rate. And it needs to be tied to specific episode-based or bundled payments, so it has to work out with whatever program is going on. And I'm finishing with this, and this goes to what some others have said, what the future holds. Well, I think we'll start with low tech, but soon enough we'll have much, much more data. Well, first of all, improved data collection and reporting, and of course mobile technology is going to be critical in this. And then not just active data collection, but also passive data collection. And the health trackers, the Fitbits of the world, give us so much data, they'll give us so much data, we have to tap into that. And then my vision is real-time genotype and phenotype big data to drive personalized medicine. When we say personalized medicine, many times we mean genotypes. I would argue patient-reported outcomes is the phenotype side, and it has to go side by side with the genotypic data. When we get to that point, then big data would be able to live to its full potential. And I'll finish with this, person-centered value-based payments. Even if I haven't talked you into everything I've said, let's at least agree this is where we eventually want to go and start on the journey. Thank you.
I want to kick off with just a little push of all of you. I felt I heard a lot about personalization, person-centered care, the quality improvement opportunities associated with big data. The payment side was a little less attended to, and yet we started this morning with sort of all these existing programs designed to reward value. So let me start with a specific question that ties to a comment Melinda made, but I think it's inherent in the other remarks as well, around the importance of sharing data across various platforms and systems. If we start tying some of the progress on these leading edge ways of thinking about quality, then it seems like there's a competitive advantage to being out front. And yet, if we want to aggregate and pool and get everyone to contribute, there's fear of losing the potential for a competitive advantage when you're jockeying for being on the good end of some sort of a value payment. So how do we square the need for this shared infrastructure with the notion that we want to pay, or that maybe the next generation of payment is associated with being out front on these kinds of issues? Any thoughts on how we do that?
Well, I'll take a shot at it from the clinical standpoint of, we've seen this within the registry community already. We're sharing the data across all the registries. And what we're finding is that the competitive spirit is all about how do they learn to make it better? How do they improve? How does that hospital that was in the red move into the middle ground and then ultimately compete to be in the green? And they want the data, they want the ability to measure themselves consistently benchmarked across their competition. Their competition, their personal satisfaction comes from then learning how they build the team to improve. And that's something we've never taught before in medical school. We didn't teach it before in residencies. We didn't teach that care is a team sport. But once you get into the right measurement framework, it becomes a team sport, and everyone then builds toward that better healthcare. That's really what we want to create, we want to incentivize to develop the value.
So that's how the clinician responds. The question is, does the CFO have the same response as the clinicians?
Maybe I'll take a slightly different stab at that, which is to say that, as Meredith alluded to, we're setting up these new systems, and we're driving people towards places where there's capital to invest in measurement and systems and things like that. And so, if anything, we're increasing that competitive advantage of being a leader, of being large, of all of those things. And maybe we want to scale back just a little bit in the other direction and try and figure out ways to make sure that more can be brought along.
Well, I'll say this. First of all, I'm not very optimistic we'll be seeing this in the near future. We're doing this in Israel right now. We have an overarching cloud system that has data for all the Israeli citizens, regardless of where they're being taken care of. All the HMOs, all the hospitals are deploying data into that system. So it's one overarching system. It took us a very long time to get there. A lot of politics intervened in the middle. A lot of health data protection issues came up. Civilians can opt out if they don't want to be a part of this, which is something that was mandated. I think in a small country such as Israel, it took us about 10 years to launch it. I think in the US it's going to take more. But I'll give you another example. There is an entity called ICHOM. I don't know if anybody in the crowd has heard about ICHOM. ICHOM is the International Consortium for Health Outcome Measurement. And what they've done is they span out of Karolinska Institute in Sweden and the Harvard Business School in Boston. And what you do there is you could sign up. You actually pay money to sign up. And then they take all of your outcome data and compare all of the other institutions that are part of ICHOM, and they have about 100 worldwide today. And people do that. People actually may pay money to be a part of this because they get back reports on what they do better and what they don't do better and where they need to improve and who they can learn from. But I think what happened here was when Sheba Medical Center, my hospital, decided to go into this and pay the money, we said we don't have any competitors that are there. We're the only hospital from Israel. So it was very easy for us to compare ourselves to the Cleveland clinics and the Mayo clinics and the big hospitals in Europe and the big hospitals in Southeast Asia because of the non-competitive nature of this database. So I think if you take away the competitiveness, and maybe there is a way to do that even here, it'll make this much more of a thing that would happen within our generation.
Let me turn to a slightly different topic, the fact we had 2 slides with lampposts. So I hear this notion of bringing in lots of different sources of data, but I just wonder if we're still going to be under lampposts, just we're maybe building a few more lights, but maybe not necessarily in the right place. So I thought the example of pollen counts is a good one. That's sort of something you can bring in. But certainly the distribution of the use of all these personal wearables is not equal across the population, and it's still very oriented towards, we talked about the Apples and the Google, David talked about the Apples and the Googles, and where they're sort of a revenue stream. We still have large parts of the social sector and even parts of the health sector, whether it's mental health, whether it's social services, whether it's education systems, that are not as invested in technology and don't have the capital that we have. And so my question is, if we're really trying to build this out, can we leave can we continue to build the way we are in terms of the investments in the data or are there gaps in data that need to be addressed with a more proactive approach if we're going to actually harness the data we need for the predictive analytics and the like?
The simple answer is there are massive gaps. We've only looked at a few conditions or diseases that are of interest for the few that have drank the Kool-Aid. When you start getting this kind of ability to leverage data for better healthcare to the general population, it creates a whole new demand. And we will come up with better, cheaper, more affordable ways of moving those other data sources in that are currently exist. We're just on the very beginning of this, and what we're seeing is phenomenal. I think it's important to remember that we pushed down this measurement system based on everything Dr. Blumenthal was talking about We set some key principles. We looked at some priorities and so forth. Bring it from the bottom up and listen to the patient, listen to the pharmacist, listen to the nurse who said, you know, this happens to me every day and we never get this right. That to me is an opportunity. Every time I hear that, I wonder how much of that can be pushed into computable science. And it's amazing how much of it can. We've just never opened that aspect of it. And when you listen to the clinicians, they're all sitting here in this sea of data and they're drowning. There are opportunities to put tools on top of that data that allow them to leverage it to better that human wear factor. And I totally agree with Dr. Blumenthal. It's the human side of this. The engineers from Google, from Intel, from Apple, Amazon, you name it, they're waiting for us to tell them what the question is. And they'll go fix it. They'll go give you the answer in computable science. We just haven't started dating each other yet.
So there's a saying that's popular at events like this, and it's that change moves at the speed of trust. And I think if you're talking about bringing in data about social services, from devices I might wear, from all these other places, and yet I don't really have any evidence that you're using my blood sample that you collected from me and I signed away my rights for, or even, looking at my record from my last visit before you see me, then I really don't want you to have those data. And I think this is a ripe area for experimentation and for sort of proof of concept. If you can tell me that my care will be better and you will use this data because you've proven it to me, through research and interventions and things like that, then I think that this will all move forward much more quickly.
I want to take the lamppost example again. So what we've done so far is basically we opened the lamppost and then we measured whatever was underneath it. Then we said, well, it's not comprehensive enough. There's too much darkness around. So we opened another lamppost and we saw what was under, and then another and another. Then all of a sudden we have hundreds of lampposts, but they're not capturing everything still. So one way would be to open hundreds of more lampposts and get to a point where we're wasting but spending $100 billion or $200 billion on measuring quality, because every lamppost takes time to measure. Another way would be to, I wanted to say reverse engineer this, but then what we've been doing was actually reverse engineering. Instead of measuring quality the right approach, we've reverse engineered. We said, this is what we can measure, now let's say it's important. Let's go to the patient and ask him what's important, and then let's go back to our drawing boards and make sure we have a way to measure what the patient told us was important, and close much of the lampposts we have today. Some of them will still need to stay open, of course. Not all of them are redundant. But I think in that direction, eventually, we'll have a much more comprehensive and coherent system that would even cost us less.
So we need to move from building more lampposts to giving patients flashlights. All right. Let's take two questions. It's been a long, full day. I don't want to extend the time, but I've dominated the questions, so I'm going to take two before we wrap up the day.
Lee Agliano, advisor to the Leapfrog Group. I guess the way I look at this is, in the short term, what I think will drive, for good or bad, is the payers are going to reimburse those and incentivize those places that give better care. And I'm talking about hospitals primarily, but it'll eventually go into community health organizations. So isn't that a good thing? Because out of that, we're going to learn more about measures of care and reward those who are giving better care. And in the final analysis, we want to make sure that our patients are getting the right care.
I'll start by saying we fully agree. I think the main reason of us getting together today is actually making sure we pay for the right care. And I would say something that might seem to some people science fiction. If I go, and again, I have my knee replaced because I don't have good enough functional status. I want to improve my functional status. And I go to an ACO and I get cared for that. The ACO get paid by a bundle payments for the hip replacement or whatever. And 6 months later, I understand that my functional status did not improve. I'm actually maybe even worse off when I was before, or the same. I would argue, why would I need to pay the hospital? I didn't get anything from the hospital. I was put under risk. I might have gotten an infection on the way. I missed some days off work. Maybe the hospital needs to pay me negligence for the time I wasted. Now, this is where I think ultimately we will be heading. There's so much on the way we need to do, but just like you're buying any other consumer, and especially for something like hip replacements, it's a good example. If you take other examples, it might not work that way. But if you're buying a TV and it doesn't work, you're not going to pay for it. So when you have a clear goal, a clear understanding of what is the value that is supposed to be given. In many cases, it's not the case, but in many cases it is. And that goal has not been reached. I didn't get anything I paid for. And I can't just say, well, we know it doesn't work 100% of the time. We told you that in advance when you signed informed consent. I think that's what's going to change, and then we're going to drive value in the right direction. Then every organization, ACO, hospital, would be working to improve the outcomes of these patients coming out of a hip replacement. Until we get to that point, I don't think it's going to happen.
I would only add that if directionally this payment system is moving us toward better care, I'm okay beginning at that point. But to the point made about, well, will the CFO live with this? If they don't understand this is a direction, that this is one step in a marathon, then we end up locking down and we have to move very slowly. So I worry about having this totally just tied to payment. I think we need to state that the intended goal is to see the innovation and reward that innovation for someone who's taking that step beyond. It will move too slowly and it'll be locked down because the costs are so critical right now. This frail elderly population that's coming is very, very expensive to take care of. And we're going to have to be much more innovative to get in front of it if we're going to stay in control of this cost. And I worry about moving too slowly on that.
Who wants the last question? Please.
This is Cleese Erickson with GW University, and I've been really intrigued by a lot of this discussion. It's been a great session. And I want to follow up on the point that you made about the patient flashlight, because I really think that is a key. I mean, it was kind of a quick remark, but I think it's really important insight. And I wondered if you could comment on maybe some of the other data elements that should be included. You mentioned, Melinda, about that we needed to be sure to risk stratify by SES indicators, but I think we also want to make sure that we're getting data into the electronic health record that can inform and build on patients' needs, like whether they're homeless or have some of these other conditions that they might shine their light on. And if you would wonder if that might be on your list of new data elements that we should be thinking about.
I guess I would make a distinction between data elements that I feel are needed, as you suggested, to deliver good care, and data elements that are needed to risk adjust at a much more aggregate and global level. And the sweet spot in terms of reducing burden and getting good quality of care is to have things that work at all levels. But I would say that that we need to work on what those key elements are. We need to not collect all of them all over the place and increase our burden. And we need to help clinicians to understand what's important and what it means for their care. And I think we're in the early days of doing that, but it's really important work.
Well, I'm going to wrap us up here with really just following on that last point that we've talked a lot about quality and quality improvement and the very rich data sources potentially for improving clinical care, but payment is only going to draw upon a subset of those, and that's probably a good thing. The question is which subset and how to do it. As we close, I want to thank our sponsors, the Federation, American Hospitals, the College of Surgeons, Blue Cross Blue Shield Association, J&J, the AMA, Booz Allen, and Premier. I want to thank you all for joining us through the morning and early into the afternoon, and please join me in thanking our final panelists.